motivate, and inspire in equal measures.
I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives, because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в 3-м поколении. Приглашается учитель физики из города, преподаватель математики в старших классах и среднем звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, диетолог из Караганды.
The prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching
The
profession.
most coveted and high-profile teaching excellence awards.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery and follow the progress of your treatment even remotely. Artificial intelligence based on deep business process analytics helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation and education. Traditionally, the Iraq
role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в третьем поколении. Приглашается учитель физики из города, преподаватель математики старших классов и среднем звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, диетолог из Караганды.
The Global Teaching Prize.
Prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery and follow the progress of your treatment even remotely. Artificial intelligence based on deep business process analytics helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation, and education. Traditionally,
The role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в третьем поколении. Приглашается учитель физики из города, преподаватель математики в старших классах и среднем звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, диетолог из Караганды.
The Global Teaching
The
Prize.
prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching
The most
profession.
coveted and high-profile teaching excellence awards.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery and follow the progress of your treatment even remotely. Artificial intelligence based on deep business process analytics helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation and education. Traditionally, the Iraq
role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision. Это ваш
Қайырлы таң,
новый
құрметті
масштаб
ханымдар мен
развития.
мырзалар, барлықтарыңызды өз орындарыңызға өтуіңізді өтінеміз. Сәлден соң біз бүгінгі іс-шарамызды бастаймыз. Доброе утро, уважаемые дамы и господа. Просим всех занять свои места. Совсем скоро мы начнем наше мероприятие. Good morning, dear ladies and gentlemen. Please, all of you, take your seats. After a while, we will start our event.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в третьем поколении. Приглашается учитель физики из города, преподаватель математики старших классов и средних звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, дефектолог из Караганды.
The Global Teaching
The
Prize.
prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching of
Детей мира и миру их талантов. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphone, progress of your treatment, even remotely. Artificial intelligence based on deep business process analytics helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. Visit additional checks. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation, and education. Traditionally, the Iraq
in equal measures.
I love that our teachers are so flexible.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в третьем поколении. Приглашается учитель физики из города, преподаватель математики старших классов и средних звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, дефектолог из Караганды.
The Global Teaching
The
Prize.
prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching of
The most coveted and high-profile teaching excellence awards.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Қайырлы таң, құрметті ханымдар мен мырзалар, құрметті форум қатысушылары, барлықтарыңызда бүгінгі
Good morning, dear colleagues, dear participants, ladies and gentlemen. Welcome to the Nobel Fest, and please take your seats. We are delighted to welcome all our guests. Let's sit a bit closer, and we're going to start shortly. Thank you.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery and follow the progress of your treatment even remotely. Artificial intelligence based on deep business process analytics helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation, and education. Traditionally,
The role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives, because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в третьем поколении. Приглашается учитель физики, логопед, дефектолог из Караганды. Вы открываете детям мир.
Today, clients can take care of their health by booking and paying for doctor's appointments using their
Құрметті ханымдар мен мырзалар, бүгінгі шарамызды 1 минуттан соң бастаймыз. Дамы и господа, ровно через минуту мы начнем наше мероприятие. Ladies and gentlemen, 1 minute to go.
Based on deep business process analytics, helps the chief medical officer manage the medical center transparently that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
В столице стартовал.
Здравствуйте, уважаемые гости и участники Нобеля.
Good morning, dear guests and participants of the Nobel Festival of Medical Innovations. Today, we're going to take a deep dive into the world of medicine, where the boldness of discovery breaks new horizons. Welcome to the future of healthcare. Nobel Fest is an important event not only in the life of our country but for the entire world, because at this platform you see the most pressing issues of humankind development. First and foremost, these are issues related to the development of approaches that related to active development. Good morning, dear ladies and gentlemen, dear participants of the forum. Welcome to this event today. We are glad and excited to have you. Welcome. We're happy to see you at the Nobel Fest dedicated to medical innovations. This festival is going to be a platform for knowledge exchange, ideas, and the latest innovations that shape the future of our healthcare. So, for your convenience, dear participants, we provided you with the translation and it's a simultaneous translation, so you could feel at ease, choose the language that suits you best, and by changing the channels. Today and tomorrow we're going to have wonderful and exciting discussions presented by the leading scientists in healthcare and innovations, and I would like to set up the positive tone so that every participant could draw a benefit. So, as Kazakh used to say, greetings is half the success, and let's do this the following way. I'm going to ask every participant to just look around, take a look at your neighbor on the right, on the left, and now let's do the same, but with a smile. Give a smile, share some positive energy with your neighbor. Take a look at your neighbor, give them your wonderful smile, and now let's do the same, but let's start talking and just say hi to your neighbor. Good morning. You can change your greetings depending on who is sitting next to you, a man or a lady. So, yeah, just be polite, pronounce this carefully, give a formal greeting with huge piece of respect. Today's forum is medicine, obviously, and dedicated to this topic. One of the most important body element of our body, part of our body, is what? It's heart, right? So heart is vital. How do we draw our heart? This way, that way. Since this is our early morning, let's do a small exercise. Just stretch ourselves. I'm going to say Nobel Fest, and you are going to greet all the participants with this or that symbol. It's going to be a short flash mob, Nobel Fest, and just show the sign of your heart. It's a heart symbol. Okay, so welcome. And now, for the opening remarks, let me invite here the organizer, director of the Institute of Innovative and Preventive Medicine, professor, academician of the National Academy of Science, Mr. Valery Ben-Berin. Give him your warm welcome. Good morning, dear colleagues, dear country fellowmen. It cannot lasts as a show for the entire day, because we academicians with academic background, so therefore the forum is now switching back to a professional fashion, and professional mode of operation. I would like to welcome the participants of this international forum, Innovations in Medicine, which is organized by the Institute of Innovative and Preventive Medicine, supported by the Nobel Fest. This forum shall enable us to familiarize ourselves with the most up-to-date, state-of-the-art data, findings on personalized healthcare, bioinformatics, artificial intelligence, different domains of clinical healthcare and fundamental studies in neuro, immune, endocrine regulation of human body, stem cells, and so forth and so on. We would familiarize ourselves with the robot-assisted technologies that are applied for treatment of various diseases and exchange scientific and clinical experience. I wish everyone a robust health, success, not only in this forum, but in your overall professional activity. Thank you. Thank you very much indeed. Dear colleagues, dear friends, we carry on, and now let me invite the founder and the director of the Nobel Festival, Maksat Korbenov. Good morning, dear guests. My name is Maksat Korbenov, and I'm the General Director of Nobel Fest. And today we are holding a Nobel Fest called Innovations in Medicine.
Fest on medical innovation. I'm glad to see a lot of friends on the opening session. Let me thank our respectful speakers and experts for joining the Nobel Fest today. Dear ladies and gentlemen, I also have one announcement. Today with us Dr. Pascal Mayer, who is the Breakthrough Prize winner 2022. And I'm honored to congratulate him with the recent Geithner 2024 prize. Дорогие участники, я рад приветствовать вас. Благодарю всех наших спикеров за участие в фестивале.
I would like to thank all the speakers for their participation in the festival. Like I mentioned, today is Dr. Pascal Mayer, who recently received the Geithner Award 2024. It's pre-Nobel. 89 Nobel laureates have received this award, and we hope that the next award of Dr. Mayer will be the Nobel Award in healthcare. So today and tomorrow we're going to have two important discussion days. Yes, indeed, I would like to thank all the participants, because you are the ones who create this festival, and it's thanks to you that we're able to put it together. And until next time, thank you. That's it from my side. Dear ladies and gentlemen, we're now moving to the third session that will be opened by the head of WHO, Dr. Edras. This record was filmed for our festival. We appreciate that he found time. Let's have a look at the video message by Dr. Tedros and give him a warm welcome.
Dear colleagues and friends, thank you for the opportunity to share some thoughts with you today. Innovation has always been a driving force in health. Think of vaccines, penicillin, or the technologies that allow us to map, analyze, and even edit the human genome. And innovation is central to WHO's vision and mission. The COVID-19 pandemic was a reminder of the power of innovation to save lives with the development of vaccines in record time. But it was also a stark reminder that innovation must go hand in hand with equity. Inequitable access to vaccines cost lives and prolonged the pandemic. Innovations are most powerful when they narrow inequalities and respond to countries' needs, rather than becoming another reason people are left further behind. That's why equitable access to vaccines and other tools is one of the core principles of the pandemic agreement WHO's member states are now negotiating. We're also working to select and scale up innovations that will help us reach the most remote and disadvantaged communities. WHO was founded 76 years ago on the conviction that health is not a luxury for those who can afford it, but a fundamental right for all people. Thank you all for your commitment to harnessing the power of innovation for the world's most pressing health challenges and to building a healthier, safer, and more equitable future. Rahmet, I thank you.
Ladies and gentlemen, I'm excited to invite Director of the Russian Gerontology Scientific and Clinical Center, Olga Tkacheva, Director of Gerontology Scientific and Clinical Center, Chief Consultant Geriatrician of the Ministry of Health of Russia. Ladies and gentlemen, honorable public, thanks for the invitation. I'm excited to participate in this outstanding event because it's going to be about innovations, and medicine is changing so fast. We're struggling to keep up with the news that is falling on us like a waterfall every day. And we're going to talk with you today about extension of our lifetime. We want to stay healthy, we want to remain active, and we want to change this silver tsunami into a golden wave that would enable us to achieve new horizons, new heights in technologies, in our prospects. And naturally, I would like to thank you yet another time for the invitation, for this openness, for collaboration. And yeah, I appreciate that we stand together. I wish you all the best in your hard work and also at this wonderful and exciting event. Thank you very much, dear Olga. And now let me invite to the stage one of the leading scientists, clinical professor of neurosurgery, George Washington University neurosurgeon-in-chief, Abdullah Institute of Neurosurgery.
Distinguished figure in the field of chief neurosurgeon of the Abdul Rauf Institute of Neurosurgery and clinical professor of neurosurgery of George Washington University. Ladies and gentlemen, Dr. Salim Abdul Rauf, please welcome.
Here in your country, I have been here a few times. I thank Professor Sherik for the invitations. The 21st century will go on to be known as the century of the brain, given all the advances that are being made. We as neurosurgeons are at the cutting edge of that challenge. We deal with some of the most difficult problems, yet we are the youngest specialty. With the young people in the crowd, young scientists and medical students, we pose to you a challenge. In doing such work, we ask you to be exceptional, not mediocre. We ask you to be virtuosos, not average. Because when you deal with situations that are life and death, you have to push yourself to the maximal limits you can to save people's lives. In my talk today, I'll present such a challenge to you. I was sent a child to me who was 15 months old, who was told by some of the top centers to be inoperable and would probably die from that disease. We put all of our thinking and challenges to save that baby's life. I will share that with you today to show you with the responsibility that we are shouldered with, so that the next generation, as they work in the neurosciences, also push themselves into the maximal limits to achieve the best. I look forward to spending these 2 days with you. Thank you.
Thank you very much. Ladies and gentlemen, and now it's with immense pleasure I would like to invite to the stage Dr. Pascal Mayer. Dr. Mayer has recently been honored as a laureate of the prestigious Gardner Prize for 2024, in addition to his earlier laureate of the World Breakthrough Prize in the Life Sciences for 2024. Let's give a hard round of applause for Dr. Pascal Mayer.
Hello everybody, thanks for being here today. I'm very happy and honored that with such a large presence, and I want also of course to thank the organizers for inviting me again here in Kazakhstan for talking at that Nobel Fest, which is a great event with great people. Just a few words, as the director of WHO said, we need to work to make progress in medicine, pharmaceuticals, in order that everybody can access medicines and can get a cure in time. Also, as we saw with COVID, that can be very timely questions. My talks these 2 days will be about that, and as an overall objective is really to leave a better world for our children and grandchildren. Thank you, everybody.
Thank you very much. Дамы и господа, теперь...
And now, it is with great pleasure that I would like to invite here an honorable scientist of the Russian Federation, Doctor of Medical Sciences, leading expert in general and molecular pathology, Mr. Igor Kvetnoy. Let's give him a warm welcome. Good morning, dear participants. It is my absolute and utmost pleasure to welcome you all on behalf of my colleagues and on behalf of our community at this festival of science that develops fundamental knowledge. It's a life worth event, a life-changing event, and we would like to organize the organization committee and our personal friend and colleague, Mr. Valery Benderin, who is our colleague and a friend with whom we had the pleasure to cooperate for many, many years, and we enjoy interpersonal wonderful relations, and it's an epoch-changing event. And I would also like to pass the best greetings from the scientific community of St. Petersburg of Russia, with the Academy of Science that was established precisely 300 years ago, is celebrating its jubileum. And in the Russian Academy of Science, there are a lot of your Kazakh scientists. There is no more precious currency than knowledge. Knowledge is wealth, is an asset, and today we as lecturers would like to put your eyes to fill you in on the most state-of-the-art achievements. We see medicine where science, art, and craftsmanship were all at the interface, and the effort is aimed to extend the life of mankind. I welcome you all once again and wish you the best of success.
Thank you very much, dear ladies and gentlemen. Now we would like to invite here our professor, the Doctor of Medical Sciences, and the lead scientist of the St. Petersburg Institute of Pulmonology, Dmitry Semyonov. Distinguished hosts, Dear ladies and gentlemen, let me share my impressions with a great pleasure. I'm really delighted to be here in Kazakhstan, to be here in this wonderful city for the first time, and such a format of this fest helps us better understand that the specialty and the surgery that I dedicated my entire life to, as well as the further development of technologies in surgery, would be impossible without the knowledge which we usually get when we communicate with each other when discussing different solutions of the fundamental science. So it is a great pleasure for me to have a chance to share my experience and my knowledge about the cutting-edge technologies. And today, on the opening day of the Nobel Fest, I would like to wish everyone fruitful work. And you know, there is the saying, never give up, keep looking for. And I think that this is key in our work as well. So I would like to congratulate all of you on this wonderful sunny day, and I wish everyone every success. Thank you very much, Dmitry Yurievich. Dear friends, I would like to cordially congratulate everyone on the opening of the Nobel Fest on Medical Innovations. We've completed the opening ceremony of the festival, and this is just the beginning. We are gonna see lots of wonderful inventions of the medical world. So with a great pleasure, I would like to announce the start of the first session, which will be presented by Pascal Mayer, who is the winner of the 2022 World Breakthrough Prize, which is the Science Oscar with the $3 million prize. And he's also the Gardner Prize in Life Sciences laureate. And thanks to the technology, DNA technology, it is possible to carry out DNA tests with higher speed and least cost. So the last but not least, distinguished Massimo Pignatelli, the Dean of Nazarbayev University School of Medicine, is going to moderate this session. So let's welcome Pascal Mayer here on stage.
And as I wanted to say in my introduction, that I'm working in a startup company. That's why I'm not wearing a tie today. I must be the only one, I guess, but that's the explanation. It's not a lack of respect. I hope nobody took it that way. Okay, so I will start the presentation now. Can I use this one also? Does this one work? Yeah, it will be a little bit better for me. Thank you. So I will be talking about can be called next generation therapies in the sense that it's a technology that's only not very much used today. It's novel. It's a little bit like next generation sequencing, for which I got the Breakthrough and Gardner Prizes. And I'm happy also to be at part of University of Strasbourg called the Institute for Advanced Studies. And so when you're making advanced studies, it's often somehow iconoclastic. And you will see that what I present is somehow iconoclastic to the mainstream pharma industry and medical practice in some sense. Okay, so what is a revolution? Actually, very often it's a 360-degree turn. That means that you make a long path to come back in many aspects to where you were when you started. And I take an example of this, which is for the car industry. So this is seen as the first ever in history car that could be called as an automobile. And it was an electric car from end of 19th century. And then this strange thing, which was the first car to go beyond 100 kilometers an hour, was an electric car also. And a few years later, people thought there's oil in the soil, we need to burn it. And we need to burn it, we need cars that use fuel. And that's the Ford T, as you may recognize from the USA. And then there were ever stronger, faster, more powerful cars. I think you recognize them. And here, even more, in this more than 1,000 horsepowers, big, huge cars, and you would see that this would be the big future, but in fact, today, maybe less in Kazakhstan, but very much in Europe and in the USA, you have electric cars replacing the petrol-based powered cars. So, question is now, do we also need a revolution in the pharmaceutical industry? And some people may say, no, everything is going well in the pharma industry. And let's take an example of this, let's challenge this. So let's think of maybe among the most advanced technologies, which is monoclonal antibodies. The cost of developing is quite high and maybe even higher. Now, of course, I took this data from some publication on the internet. And so it looks great. So take a case study like daclizumab, complicated name. That's very interesting. It blocks IL-2 receptors, but not any IL-2 receptors. Only the ones that contain the alpha subunit CD25. I personally do not know exactly what it means, but it's very precise. It's not anything. But when you dig further, the experts say that, well, in fact, the mechanisms are finally not known exactly. We have a very precise knowledge of what we are targeting, but in the end, we do not really know what it does. The net effect is working on T-cell responses, and as we say, expansion of CD56 natural killer cells, not CD45, not CD75, CD55. Very precise medicine. But still, it was put on the market, and surprisingly, it had to be redrawn because of toxic effects. So despite the fact it was really precision medicine, based on good science, that's not the question, based on very important and good science, but in practice, in the end, it was not a good treatment that costed a lot of money that was thrown away. And the money question is very important because experts in finance say that the cost of developing drugs today has gone so high that in the end, it's no longer economically interesting for an investment. So what will happen soon? Will it be that no new drug will be developed because the costs and the risks are so high that nobody will do it? So you may say it's necessary, we need them, but let's look at another aspect. Here it's about antibiotics. Antibiotics are life-saving drugs. They have been mentioned for good reasons as having made a revolution in medicine at some point. That because of the development of bacterial resistance, they are getting less and less efficient. And also they have a strong negative environmental impact, which is not only bad for the environment, but also in the fact that it contributes to the development of resistant bacteria, which in the end make that the antibiotics, the current ones, won't work, and we may again go to a work where no neurosurgery could be possible because of the risks of infection. So other things, how the drugs, at least the small molecule drugs for biologics is a little bit better, but that's huge factories, not very nice, polluting, and it takes time to develop a drug, even as has been mentioned for the development of the anti-coronaviruses. It took months, and before that it would have taken years. And during that time, in case of pandemic, people are dying. So the time to get an efficient drug is important. It's not solved yet. And there are some places in the world where there are riots to get access to medicine. Here is an example in Venezuela, but there could be other places. So, but you may say, okay, that's the price to pay, but still, let's look at on oncology and a big company, Bayer, who is very proud of saying that they went from magic spells not very nice to the ancient medicine, but from magic spells to precision medicine. Wow, great. But there are still people in the world that can't get the cure and are dying. Here is an example of somebody I do not especially know, but it's on the internet. It's a guy who's writing books, and he's dying of cancer. He knows it, but nothing can be done. So I would say, how can we understand this? Let's look at what is precision medicine. And I'm not the only one saying this, and I know some Nobel Prizes, people who say the same thing, or former executives of pharma industry that say the same thing. Precision medicine is to say, okay, we know a target, we have identified a gene, something, and we are going to develop one compound that acts with that one gene product, and we get a biological effect. That's the idea that is rarely true. Sometimes, but very rarely. The realistic view is to say that when you have a compound, it will indeed act on the target towards which it has been developed, of course, but it will also act against many other targets. And that's how people think of generating adverse effects. But this you may think eventually with bioinformatics, chemoinformatics, you might solve it, but in reality that's not even good enough a picture. But a science called systems biology, which is now progressing all over the world in the universities, in the academics, is teaching us that actually a drug can act at a certain point towards which it has been defined to, but maybe also in others. But there's network in the metabolism, in our biology, in the cells. And you can interact with one target at some point, but because all the genes, in some sense, are connected to each other, you can have biological effects far away from the point where you intervene. And so that seems to be solutionless. Think of the daclizumab. It acted very specifically on the green spot, but still there must have been some very complex network effects that made it strong adverse effects. So I think, yes, we indeed need a revolution. And as a French person, as you may have got from my accent, sorry for this, this is a picture of a Prise de la Bastille that marked the beginning of the French Revolution in the end of the 18th century. Okay, so what can we do? Let's change the strategy on how we look at the mode of action. And what I'm following is something that is inspired in some sense of a strategy of 1,000 cuts. So it's from a historical general named Sun Tzu, who wrote books also and who defined that strategy. That's instead of hitting very hard on one point, is to hit not softly but weakly, but on many, many different points. And that translates into what can be called cellular systems perturbation. That means you will perturbate only at different points in the cells, in the systems biology of a cell, with many different compounds. So it would look a little bit like this. So instead of having one compound acting on one target, you have many compounds acting simultaneously on many different points. Most of them would push the biological property in one direction or in the other. So on average, many compounds acting on a certain target will have a neutral effect. And it can be shown by statistical means, which will give you the effect. But in some cases, you may have all these compounds acting synergistically on many different targets, just perturbating it, for the experts, perturbating the conformation, perturbating the enzymatic activity. There are many biological, biochemical and biophysical effects that can explain this. And eventually you get the biological effect you expect. And because most of the effects are neutral, you may hope, but we need to look at in practice, that you don't have adverse effects. But the question then is, where do we get this high, massive diversity of compounds? If you make novel chemical entities, it would be untractable because you would need to verify the toxicity of each novel compound. So the question is, in order to make this practical, the idea was to say, where can I find compounds that are reasonably safe and where the risk of side effects will be very small, if any? There are not that many compounds. There could be the compounds that are inside our organism, but that would not be very practical. And when you think about it, the only source that you can think of and taking inspiration from some recent science, including one that I did on explaining the statistics of such an approach, is on mix of edible plant extracts. What we eat as food, what the world, all over the world is eaten as food, contains many, many different compounds, and globally they are not toxic unless you eat too much of them. And I want to give you one example. Think of water. If you drink more than 4 times the recommended dose of water, you are at risk of having strokes. So even water can be toxic. So that's an idea. So what would it give? First, there's a paradox which I mentioned. The food contains a large number of compounds, but it's not toxic per se. So as we know that when you make polymedication, you can have strong side effects. So there's a difference between drugs and compounds contained in edibles. And the authorities like this because they recommend you to have a highly diversified alimentation and to eat 5 to 9 fruits and vegetables. And they never made a clinical trial to see if all the possible combinations have toxicity effects or not. And making the statistics, you understand that the risk is not zero, but it's very, very, very low. As when you go in a restaurant, in a Chinese restaurant or Indonesian restaurant, you don't worry that what you eat, because of that recipe, you will get sick. That's common sense. Could be, there's small, very small risk, but you neglect it. And so when you're eating 5 fruits and vegetables a day, you're making massively parallel pharmacology. It's naturally safe, and the health authorities believe this. That's a good start. So to make this tractable, what I thought of doing is to make, well, it's not especially new when you're making a juice extract, you're doing it, but we're making water extracts of edible plants, and the idea, again, for the experts, making water extracts, think that when you're making pharmaceutical discovery, you are discovering a compound that is soluble in DMSO. You have a hit, you are very happy, and then you spend 2 to 5 years in order to get that hit, which is soluble in DMSO, to get it soluble in water. So as a trick, make water extracts, you're sure the compounds are soluble in water. That's for the experts. And also, if a mix are synergistic, they can be patented. And we know, for those who are familiar with the pharma industry, that no patent, no drug development. So it can be patented, and we did it. But there's a technical issue. If we take a library of 30 to 100 edibles, and that we want to make mixes of it, and I forgot to say why we make mixes. The reason to make mixes is that if you have a single botanical, it will eventually have a certain effect, which are known by tradition. Many of them are known. And so you don't have much latitude of orienting the activity. But if you take several extracts and you mix them, you may have the possibility to orient the biological effect by playing on the mass of small effects that act on the biological system, and you have that 1,000 cuts strategy. So each plant has 50 cuts, And by choosing the different plants, you come to 1,000 cuts, and you can hope to orient the activity and come to the activity that you want. But when you're doing this, there is a mathematical problem. By a library of a few hundreds of edibles, and if you make mixes of 5 to 20 edibles, which turns out to be a good number, there are up to 10 to the 40 possibilities. And no pharmaceutical company will ever be able to test this, even maybe in computers. So the traditional brute force is not an option. And to overcome this, what we did is to use AI algorithms. We didn't load them from the internet. We are doing this since 2015, so before everybody is now talking about AI. And we will see that they enable this revolution. I'll give an example. That's the way how we do it. So this was what we experienced when we were doing our first discovery based on discovering antimicrobials against Staphylococcus aureus. In this graph, each bar represents the effect that we measured on the growth of a bacteria and on its ability to attach to surfaces, to make biofilms for the experts. And each bar represents the combined effect of these two phenomena. And initially, we start with random mixes in order not to make hypotheses and not to be perturbated by what is known as only very little is known about the effect of plants. So the idea is to sample the whole space of 10 to 40 possibilities. So this gives us some small effects. Here the images are snapshots of real experiments. You see that the blue, sometimes it's really blue, sometimes it's more violet, that means some activity. And we take these measurements, these combined measurements, also the growth of a bacteria, and we put them into our algorithms, and also the composition of the mixes. And the algorithms, literally, they learn the relationship between the composition and the observed biological effect. And they propose us to improve our experimentation. We can very, very quickly the efficacy of the water extracts that we used. And in the end, we were able to get full growth inhibition and full biofilm formation inhibition. And the MICs are not ridiculous. This was really for our first discovery. The MIC 90 means that 90% of bugs are inhibited at this concentration, but by being. We had to have true MICs down to 200 to 100 microgram per milliliters, which is the efficacy of traditional old traditional initial antibiotics, chemical antibiotics. So West is very loaded. Just to say that we verified it worked on many strains, I already said, Staphylococci, and many of them are multi-drug resistant, so resistant to several antibiotics. Our product still works. It's normal. It's expected. It's a very different mechanism of action. One critic to plant extracts is that it may not be very reproducible. We addressed this, and this is in the lower left, the data, but I won't discuss it here. And also, we tested it in animals, and we had the good surprise of seeing that we were able to save life of mice that are infected by systemic infection. And the treatment was administered by ingestion. So despite the fact that these are extracts of edibles, they can have an activity by oral administration as any other antibiotic. So here it's 50% after the septic shock, which is the initial decrease. And so like in human, you can have, because of at a dose, 100% after the septic shock. So it's patentable, just to say, for those who may adopt it. It has been granted already in 15 patents, and the European Patent Office, we got the letter of intent to grant, so it will be granted. It will be issued improved in many others. And the list here is, there are some that are critical to WHO, some that are of technical or veterinary, and agronomic interest. And what we understood, they like to live glued one to the other and attached to a surface, which is called a biofilm. And the immune system is unable to kill the bacteria in the biofilm, and most antibiotics are not active on the bacteria within the biofilm. It's a bit too long to explain why. But because of this, you can have many diseases. I put some here that are that could be linked to this. At least some researchers found a relationship between the presence of bacteria and the disease, especially in Alzheimer's disease, as there's a question a lot of longevity in this conference, of rheumatoid arthritis, also of interest, I guess, for aging people, and also a very interesting paper from a group in Mayo Clinic in the USA that found that, in fact, we might be just infested by bacteria in the body. They don't usually have a strong effect, but they can explain some level of inflammatory status. And when it goes too acute, you can have inflammatory disease and then have the debilitating consequences of it. So there's a need to really dislodge these bacteria. Could be treated once you discover that the bacteria are here by immunotests, for instance. And of course, as you can imagine, I think we have good candidates for this. Sorry for bringing this to me, but there's overall science, and I have the lack of humility to think that maybe we have something to fight against it. So this approach worked not only on the bacteria, also on some fungi, on viruses. I may present this in one of the other talks I will make, in dog, on topical, and on human. We have some results on a few things, because you hypothesis and rituximab. In terms of return of investment, I can spend 10 minutes on that slide to explain why it allows to have a much better return. So, yeah, return is needed in pharmaceutical. I'm working on a possibility. We'll see. Time will tell. But it's a revolution again, because humanity used to heal itself with botanicals. That's well known. And the Chinese still use a lot of traditional medicine based on plants. But at some point, that knowledge has been destroyed by elites. I'm putting, I think, as a clin d'oeil, a small joke, Rasputin also, that is maybe on these elites that really killed that ancestral knowledge. And 20th century, the pharma industry, which I don't represent very nicely here. Of course, very likely I'm alive thanks to them, so it's not a lack of respect. It's just to say that, okay, guys, you may need to move. And of course, I'm the hero. I have a proposition to go beyond this with artificial intelligence, with return to natural products, with a strong biophysical basis. There's mathematics and physics behind, but it's a statistical approach based on natural products that can be grown in the field, also off fields, so to reduce land use, and the waste is not of any problem, of course, to the contrary of the chemical industry. Okay, that's the end of my talk. Thank you very much, and I hope we have time for some questions.
Well, we invite the moderator of this session, Dean of Medical School of Medicine of Nazarbayev University, Mr. Massimo Pignatelli.
Thank you very much for this wonderful presentation. And I would like to start my first question, really to perhaps a provoking question. Obviously, you're using an approach where you are mixing a different compound. And I just wonder why, how you are selecting your biological system. Because obviously, the biological system where you're going to test these drugs must be well-defined and precise. So can you just tell us some ideas about how you develop these systems?
Yes, thank you for the question. The idea was to be humble and to say we don't know everything about biology. So rather than following one protein in a test tube, I thought it was better taking advantage of the technologies that have been developed that is called high content screening, is to look at the global effect on the cellular level. So either on cells, human cells, or on the bacteria, or cells infected by viruses, and so on. So in the end, you don't follow a hypothesis that this gene, that making good science you found is involved in the process. You don't make the hypothesis that this is the very key of it, but you say, okay, I look at the whole process. I just put the mix of extracts. I'm nearly 99.9% sure they don't have strong or notable toxicity, if any. And if I see an effect, I know that there could be efficiency. Of course, there's still the hypothesis that the cellular model that I have is representative of the disease, but for bacterial infections and virus infections, it's not too bad. And for cancer cell lines also, it's the cancer cells that are the problem in cancer more than all the rest. So it allows to make reasonable experiments and not to take the risk of making the wrong hypothesis, as history told that was often the case, despite the fact, and I want to stress this, that I consider, I'm very respectful of this, there's good science behind, but science and making an application are two different things, right? One needs to be true, the other one needs to work. It's a different approach.
Thank you very much. And in fact, in a way, you are redesigning the concept of precision medicine, because it's still your experiment are really what they're actually trying to move the precision from the individual molecules to the actual biological system. Because at the end, you want to develop a drug which is going to be precise in terms of the biological effect, rather than just looking at the individual target.
Yes, I compare this often to thermodynamics. I think most of you to the least, I guess, remember more or less that relationship for perfect gases, which is PV equals nRT, where T is the temperature. So this comes from a statistical analysis. It's also seen experimentally, but the explanation is the statistical analysis of the behavior of huge numbers of molecules in a gas, and then it has been expanded to very other things. So it's a little bit like the same in an engine or jet engine. You don't know the position of each molecule. You don't know exactly at which rate, where the chemical reactions go on. But the statistics of this phenomena allows you to predict very precisely the yield of engines, the maximal theoretical yield of an engine, that allows you to know that it's better to have electric engines instead of hydrogen combustion engines, for instance, and so on. So that's the idea behind.
Thank you. You obviously mentioned how expensive it is to develop innovative drugs, and we have many examples in the literature. Can you give us some indication how you compare your approach in terms of cost and in terms of the time to get an outcome, you know, to develop this the actual drug and to go into the market?
Thank you. I will split it in two. One is the second part, which is the clinical trials. The idea that we have here is not to make soft medicine, is to make really hard medicine in the sense that it's evidence-driven medicine. So we need to make clinical trials, and the clinical trials have the cost that they have, and we don't have an effect on the cost of clinical trials. However, for a drug company, many clinical trials fail, and because we reduce the costs, the risk of failure, we globally reduce the cost of clinical trials on average in the drug development process. Then is the first part, the preclinical one. The preclinical one can go quite quickly, from reasonably quickly, after a few months, 1 to 2 years, let's say, if you want, if you work in France, we have 35 hours a week working time. So if you respect all this, I would say 1 to 2 years. But after 2 years, you have a product that can, in some countries, especially the USA, potentially go directly into clinical phase 2. Because if you choose as a starting point plants, botanicals that are edibles, that are considered as safe, where even the FDA would believe that they are safe and that a recipe of them is still safe, you can go directly in clinical phase 2. So you spare all the preclinical, the toxicology studies, the phase 1. So you gain typically 2 years, 2 to 3 years. And this is then important on commercialization, because you patent, when you start the preclinical work, basically you file the patent and you have 20 years to exploit your product. If it takes you 10 years with the classical, when everything goes well with classical pharma development, you have 10 years to exploit it under patent protection. By going with the WECMAPS type, you may gain 3 years. And 3 years at the moment where the sales have grown and where you make the maximum profit. Whereas with when the patent fails, usually your sales drop. So in terms of time, I would say 1 to 2 years, but with some exceptions. If you would organize consequently for discovering a novel antibiotic, it could be as quickly as 1 to 2 days. And for viruses, 1 to 2 weeks. And eventually for personalized cancer treatments in some utopic thinking so far, but maybe one day it will come. You would take a sample of the tumor, and in the lab, within 1 to 2 weeks, you could develop a water extract, a WECMAP, that is active on that specific cancer cell line. That is possible, but you need special organization in that case. And of course, the health authorities must at that stage say, okay, you can go into clinical trial next day of the lab discovery, which would be possible in terms also of a production process, which is much easier. You don't need to build a specialized chemical setting to make complex chemical reactions and to purify perfectly your product. Here, it's a food preparation process, basically.
Okay, thank you. I was reading your biography, and you obviously you are a biophysicist by training. Perhaps you can also tell us what biophysicists do, how they integrate physics and chemistry and mathematics to biology. And what I was very impressed that you built up your career as an entrepreneur based, obviously, a very solid scientific training and reputation. And then you move into the entrepreneurship, and you founded your company, the current company, Alpha Nosos, 10 years ago, as a startup, really focusing on NI, that's correct? Yeah. So what type of advice you can actually give to our young and enthusiastic students and professionals who actually want to really also develop something innovative in medicine?
let me give two advices. One that I would give in France would be to move to California. I think in Kazakhstan, from what I'm seeing, you can imagine it's a surprise for somebody coming from France, but I think you may be in a very good country to develop startups, and especially medical startups, because from what I see so far, I cannot tell what it is in reality, but from what I see, at least, it's very encouraging, very motivating, and I think you are in a very good place to do it. The second advice would be to take advantage of what is at your reach, and that's what I did for the next generation sequencing that I'm doing here in Alphanosos. For next generation sequencing, I didn't have access to microchip technologies. I didn't have access to big lasers. I had a microscope and I had PCR reactants, and my thinking was, what can I do with this? And it takes time to find something. It's not just like, okay, well, I can do something. It's a big effort. You need to think a lot, to have a lot of imagination. So build on your imagination and focus on what you can do. And in Alphanosos is also what I did. I was familiar with artificial intelligence. I had no access to chemical synthesis, and I'm very poor on organic chemistry, actually. But I could have access to botanicals, and making water extracts is like making tea in some sense, so it's not a big deal technically. So I really focus on what is in your hand, make your imagination work until a point you can do something novel, innovative, and game-changing with what you have at your disposition, even if it's not the latest technology that is found in the biggest lab of the biggest country of the world.
Okay, thank you. And obviously, there's a lot of emphasis on in areas, particularly in medicine. So again, looking at your graph and what you're achieved, again, an example how you've been working with professionals. I won't get into physics, if I may. Tell me, how important been that in terms of actually, I mean, this discovery, which is obviously the first one, which was the NGS, the next generation sequence, which actually transformed completely. We sequence DNA, particularly obviously during the COVID, everybody actually were able to actually appreciate and find out the impact on these technologies. In general, how important for your training and your background?
Yeah, you are right, and I was saying to what if I was you are and it's not for young people are important the knowledge generated, but to build inventions, to create tools, to do things. And you cannot be at the same time expert and a multidisciplinary person, I believe. And biophysics, I chose them because it happened that I was interested, like I guess many of the young people here, by many different parts of the science, and molecular biology was emerging. There were already questions about artificial intelligence 50 years back. I can only advise trying to find a movie named Colossus, which is about artificial intelligence, which is very interesting. And so these things were around, and I was interested a little bit by all of them. And I had some sense that of a biological system, but not knowing as it's known now. You can imagine a 16, 18-year-old person thinking about this. It's not, don't take me as a genius. I just try to make, to have a technique to make things that are interesting. As that. So, but still you have that fuzzy feeling that there's a biological system, that there could be some intelligence there, and it's a physicist point of view, it's a mechanistic thing. So I went to biophysics, and this made me end in Strasbourg, which I'm turning a little bit back now.
Okay, thank you. Then perhaps my last question to you is, can you tell us what is can you project for us in the next, for the next 5-10 years? So what do you think will be the next big discoveries? or what is the area that really perhaps we should all need to be focusing on, really to make that impact on the health and well-being of the population in the world?
Well, that's a difficult question. To me, what I see of the most impressive in medicine is surgery, because they are basically resuscitating people. Also, emergency medicine then is for me the most impressive. And when you see the rest of the medicine, it's not progressing very, very much. And so the reason could be that we are not looking at the right place. Possibly that's my opinion, but so far I can be wrong. But I think people need to accept, to look to the fact that many of our diseases could be due only to microorganisms. And if this turns out to be true, to be accepted by the experts in all this field, in the inflammatory field mainly, there could be very quick progress. So for me, this is one of the most important things, and eventually to make personalized treatments, but this is in some sense a technical detail. I think the most important thing will be to go back to the possibility that many diseases could be due to the presence of infecting agents in our body. Silent ones, not an acute infection where you die of, where you suffer directly, but where you suffer the immunological consequences. And this is a big thought shift that is very difficult to make. There are people who are working since 20 years by having, for me, quite convincing evidence that bacteria could be involved in Alzheimer's or other type of brain diseases. Have been done, also seen very well in some deers in the USA. But it seems to me that most of the neurological experts don't believe in it. They see plaques, they want to avoid the formation of amyloid plaques, but it seems not to be working. There have been some medication and they failed basically, and it seems to be very difficult for them to turn to the possibility that microorganisms could be at the source of it. Of course, there are no microorganisms in the plaques by themselves, but there could be the immunological trigger of that problem, also in cancer. And it has been even very recently, there have been some groups working on the fact that there are bacteria in the tumors and that they could be some kind of, have a very important role in maintaining the virulence of the tumor. Maybe, I'm not the expert in these fields, but I think that the medical community should focus much more on this, and this could then be the biggest revolution, because then with some antibiotics, some antivirals, you could cure 90% of the diseases, maybe the diseases that are involved in elderly persons and prolonged life like this. But I can be wrong, I could be wrong.
No, I think it's a very good suggestion, because I mean now with the microbiome analysis and sequencing, we actually now we're finding out that the bacterial flora has such important influence on many diseases, not just in the intestinal tract, but also in the brain and other chronic disease. So I think that is a very exciting and stimulating actually approach that perhaps we may need to think about, really to think about out of the box and look in disease in a different way, but always with a multidisciplinary approach. Well, thank you very much, Dr. Meyer, for this very interesting and stimulating presentation. Thank you very much for visiting Kazakhstan. And we have there are a lot of opportunities in our country here, and we're really looking forward to exploring with you. Thank you very much. Thank you.
Thank you.
Thank you very much, gentlemen. Құрметті ханымдар мен мырзалар, шарамызды одан әрмен
Distinguished ladies and gentlemen, we are proceeding with our Nobel Fest. We'd like to welcome our we'd like to invite here Olga Tkacheva, Director of the Russian Gerontological Research and Clinical Center, Chief Freelance Geriatrician of the Ministry of Health of Russia. Berin will moderate this session. He is the Director of the Institute of Innovative and Preventive Medicine. Let's welcome them here on stage. I don't have a clicker, unfortunately. Distinguished colleagues, I would like to say a few words about what is aging and can we actually manage aging. Is microphone working actually? I cannot really hear myself. Well, seems like it is working now. Am I gonna have a clicker, dear colleagues? Or how about you switch slides then? So, the expected life expectancy is going up and quite rapidly, and in the last 100 years, the expected lifespan increased by 30 years almost. And it was possible thanks to the technological development, including the development of medical technologies. So I'm not gonna have a clicker. Is that right, colleagues? Well, then next slide, please. So it is quite interesting to see that the average life expectancy is also going, but as for the maximum life expectancy, it doesn't go up. Today, the maximum life expectancy, as you all know, was registered in one of the countries where Jeanne Calment had lived for 122 years and 64 days. And we haven't seen anyone who lived that long. We haven't seen any other champions in maximum life expectancy. So there is a question, can we actually affect this indicator? Can we actually change the maximum lifespan? And what is it affected by? So gerontology is developing rapidly. So indeed, we see more and more academic papers, scientific papers in the most prestigious journals such as Nature, Science, and there are some editions of those journals that are dedicated to the processes of aging. One of the latest publications which completely reflects the mechanisms of aging was describing these 14 indicators that affect aging. That's the genome instability, epigenetic instability, loss of proteostasis, chronic inflammations. That's what was mentioned by the previous speakers, inflammaging, cellular aging, dysbiosis, and so on and so forth. So the process of aging is quite complex. And our objective is to understand how aging looks like and how can we actually influence the process of aging. Well, first of all, I just want to say that there is the biological age and the passport age of every human being, and they're not equal. You know very well that people of the same passport age may have completely different biological age. They may look completely differently. They have different activities, different physical and cognitive activities. They may have different skin quality of their brain may be different. So the variability of under different scenarios, I will tell you, by the way, how to determine the biological age. Well, by looking at this graph, we see that there can be different scenarios. For example, we can age very quickly, which means that our passport age will be a bit behind of our biological age, or vice versa. We will age very slowly, or we will age in line with our passport age. So we see the differences which can reach up to 20 years. In our center, by the way, we looked at the biological age of people who reached 100 years. I'm talking about good I'm talking about good cognitive and physical parameters among people who reach the age of 100. And here we saw a significant difference between the passport age and the biological age that would amount to even 20 years or above. So this is one of the publications where, as we see, the chronological age of the participants of their research was 38 years, but you can see the spread of their biological age, which was assessed with the use of a so-called biological age calculator. So I will probably provide a few pieces of information about such a calculator later, but indeed today we see this perception. Well, if we thought that our organs age at the same speed, now we realize that our organs age at different speed, at different velocity. And in order to determine the biological age, we need to look at the biological age of our cardiovascular system, of our metabolism. We need to determine the biological age of our cognitive functions, of our organs of vision, for example. And that is why different calculators are developed on the basis of different biomarkers of aging. One of those calculators of biological age was developed in our center, and this is the calculator of the biological age of vessels, which is based on the assessment of the rigidness of the vessel walls, which means that we see the arteriosclerosis. We look at the arteriosclerosis, which with over time helps determine the biological age of vessels and gets correlated with the actual age. So by using such a calculator, we can actually determine the age of our vessels in the organism. There are also other different calculators that determine the biological age. We have the deep gematological watch or clock, which works on the basis of indicators of the peripheral blood. There is a so-called microbionic clock, which shows the age of the microbiome of our intestines. We know that microbiome gets old together with us, and over time it tends to change. It becomes less and less variable. And if we go back to the research of people who turned 100 years old, well, we published the results of this research, and we showed that the microbiome of the intestines of the older people is similar to the microbiome of younger people. They show high variability. They show lots of lacto and bifidobacteria. And here is the question: do they live for so long just because they have good microbiome, or they have such a microbiome because they are healthy and that they've been living for so long?
Well, both the cause and relation are hard to tell. Well, there is a famous gerontologist, Professor Zhavoronkov, who has been offering a lot of calculators and calculation options for gerontology age. It's microbiome hours and different type of hours, photo hours that can tell you the biological age. So there are different markers that could be selected in order to find the calculator, such as methylation, that best correlates with the biological age of a healthy person. And on the basis of this marker, they create calculators of biological age. And so first that we need to learn is to measure the speed of aging, because if we can't measure speed of aging, we cannot change it. All studies of aging, they're lifelong, because the end point of this aging is what? Extension of expected lifetime and life expectations, and not only life but also healthy life extension. Naturally, you can do this kind of tests with short-lived animals, but we need to bring it to the clinics and some surrogate markers manage to do that, we can test these technologies that can extend their life. Because some people feel that the drugs that help us treat some chronic or infectious diseases, they all extend lives. And at multi-profile clinical studies, it's proved to be wrong, because not all drugs, they lower overall mortality, they only hit certain points. So if we learn, and we are learning gradually to measure speed of aging, can we influence life expectation? Can we influence the speed of aging? Is that possible? And how can we measure the speed of aging? Many people feel that it's predominantly determined by our genetics, though as a matter of fact it depends on genetics only by 25%. However, if we speak about people of senior age that lived 90 and 100 years, then genetics play a more important role in longevity. Maybe you know there is a classification of 100-year men. There is a classification of young 100 years, medium, young. Well, basically for us to be young, I can tell you that after the age of 80, we need to turn young again. We need to last until 100 only. But there are very few of those that live till 110. There's just a handful of people, and that's most of all depends on genetics. Naturally, the lifestyle matters, medicine matters, behavior risk factors, and when we talk about what's proved, then once again I would like to tell you that gerontology is the science that works with in experiments with the cell culture, and there are not so many clinical studies, and that's why we're trying to translate knowledge from experimental gerontology to clinical. And there are very few publications that show how one's lifestyle impacts life longevity, and the factors such as healthy lifestyle, they add 3.5 years, and if we add all 4 factors: physical activity, no smoking, reduced alcohol consumption, and healthy nutrition, it adds up to 40 years. So when we're looking for Macropolis tool that extends your life, then we need to remember that the basics here is the lifestyle. And other studies where super longevity can be traced in the family. Sarah Bernard family, that lady, she lived 119 years old. She survived 23 presidents of the United States, and in this picture she's with her son, her daughter, who is 94, son, who is 76, his daughter, who is 48, their grandchild, who is 24, and the kid is pretty young. So there are 6 generations in one picture. So here is the demographic situation that I think is waiting for us in the future. Naturally, we've been talking a lot about the age of associated diseases, and in fact, I'll be talking more about today. How do we determine aging? There are 2 definitions of aging. One is the deteriorating functions, physical, cognitive, sensory functions, and the other is age-associated diseases. The diseases that reflect aging per se. Alzheimer's disease, for instance, is a disease of aging, and we know today that there's a bunch of genes that are associated with age-associated diseases, and a series of genes that, on the contrary, protect us from development of these age-associated diseases. Well, there are a whole lot of studies that demonstrate how we can protect cognitive function from aging. And I'm going to tell you more about it later. And as you can see that indeed, when they started to tried to research lifestyle of 100 years old people in the Netherlands, it turned out that they have higher socioeconomic status, higher level of education. Most of these participants, they lived independently. They preserved good hearing and eyesight. They were mobile. They didn't differ in terms of alcohol or smoking from others, and they also had some neuroprotective alleles, and they had fully preserved cognitive function, and we see a lot of publications of this about superagers. These are the people whose brain is not aging, whose attention, concentration, perception of new things remains the same as they were young, as when they were young. And it's an interesting phenomena that is being scrutinized currently, and indeed a lot of people feel that genetics playing an important role here. So genes are researched that are related to aging. Protective genes, they're hugely important. And how we can influence the age, the process of aging. There are different geroprotective technologies. The most proven geroprotective technologies, no matter, maybe we would like to see some magic drug that would extend the life, and we realize that the process of aging is super difficult, and it's proven today that physical activity influences process of aging, that it slows down aging. Certain type of nutrition habits, they also have effect on aging, and naturally there is a database on potential geroprotectors. There are around 300 of them. Here you can see some and what mechanism they influence. Metformin influences 3 mechanisms: cell aging, intercell communication, destruction, insulin sensitizer. It affects level of systemic inflammation, and metformin is the first drug that is studied in clinical study as a geroprotector. It's called TAME. It recently began. It's a hard to do study, a study where the endpoint, where they focus on the first age-associated disease. It's a lengthy study. It just began, and so far there are no other clinical studies of that size. It's a placebo-controlled study. You see that among potential geroprotectors, it's curcumin and aspirin, because it's an anti-inflammatory drug. Curcumin, quercetin. There is no geroprotector that would influence only one mechanism of aging. As a rule, they intertwine. Just like the geroprotectors, they also mixed and they vary. You see, it's an interesting approach when we assess geroprotective technologies with the help of some aging markers. In dynamics, we can see them, and depending on what geroprotective technology we apply in our research, we use these surrogacy points that you see on the right. By the way, it's an interesting study these days that are related to, it's not a mechanism of aging, but anti-aging It's an autophagy mechanism. It's regenerative medicine, gene engineering therapy, transplanting. These are not only gera protectors that we spoke about earlier. There are a lot of centers these days that study aging. It's Max Planck, Bach University, and a lot of them mentioned here. It's not the full list though. However, 2 years ago, as part of the project called 2030, our Russian Gerontology Scientific and Clinical Center has received funding to start the institute focusing on studying aging. It doesn't mean that we began our journey 2 years ago, but indeed we are, we're studying this problem a long time ago. We've been doing so. So what are we focusing on today? We study different aging, scenarios of aging, successful aging, accelerated aging. We are developing different biological age calculators, which we are learning how to measure speed of aging. We study different geroprotective technologies, and we have synthesized successfully very successful molecules. And a separate area of our work is when we study brain aging. We are covering Alzheimer, and we have an expert Alzheimer center in Russia where we can set the right diagnosis using beta amyloid and tau protein, and as well as liquor. So we're trying to cover this problem. What is there so extraordinary that we can cooperate? We have a massive biobank. It's unique in terms of even global achievements, because in our biobank there are more than 5,000 patients with samples of different patients. They are long livers and super long livers. They are people older than 90 and 100 years old. Why are we trying to research long livers and super long livers? Because we want to understand what is the recipe, what is the scenario, the model for a long life. We are also assessing the preservation, because in 100 years old you can be fully dependent on external aid. You can be also independent and biologically much younger than what your passport tells. And in our center, we're studying Rus age. It's a study where we study, where we research healthy people, well examined, who have very low diseases, and on the basis of these aging markers, we're trying to come up with a biological age calculator. One of these calculators I've already shown. This is a new calculator. It's called ECO-Age. It's a biological age calculator for the heart, and it's the first result from Rus age. Because Rus age is different from other similar studies in the world. There are analogs such as Mark H in Europe and Baltimore study in US. That's been going on for a few decades, and today at the lecture I will try to compare how is Rus age different from other studies. At our center we develop senolytic active compounds and mixtures. We have a laboratory that deals with senolytic. These are also called xenomorphs. These are molecules that help us be deprived of old senescent cells that have toxic effect on the neighbors, and they make neighboring adjacent cells grow old. And in order to curb the toxic activity, we are applying senolytic drugs. Besides this all, like I said, we are dealing with Alzheimer's disease, and indeed we have a lot of dimensions for cooperation. We are studying phenotypes of Alzheimer's disease because the course of this disease could be varying. It could be progressing quickly or not so fast. We are trying to come up with a blood test to determine Alzheimer's disease. As you know, to set this precise diagnosis, that would help you to use monoclonal bodies to beta-amyloid. We need to do liquor study and beta-amyloid and tau cell in liquor. If there was a screening test or blood test, we would be in a much easier situation. A few months ago, we opened a longevity clinic at our center, where we started applying calculators of our biological age with the first examination of a patient, and then by elaborating its treatment. It doesn't have to be geroprotectors, because geroprotectors today, as such, that have proven base in randomized placebo clinical control studies, they're absent. However, any drug, any interference, this way or another, we influence not only the disease but also aging process, and we assess not only the course of disease, but we also assess the aging process. And this also helps in our scientific studies, but it also helps to match individual strategies. These are calculators that will appear shortly as part of research. We have a lot of partners whom we cooperate with. This is immunology hours, microbiome-based hours. And now it's really tough to go in details of this topic within 20 minutes, but I see and hear a lot of skepticism. How to make a person younger? We are just saying that we can influence, we can affect the speed of aging, and we're talking about average life expectancy at birth. But we can help dreaming to extend one's lifetime to the maximum, and it all depends on the understanding of the future. With this mural, this mural is 20 years old. If the author used to say that people will never move faster than a prancing horse, he was wrong. He was wrong, but he was right for 9,100 years. It means that it's the goal, it's a achievable goal. It's not unsurmountable to extend our life, at least as far as a healthy lifestyle is concerned, and to shorten the period of life with diseases when the person ceases to be autonomous and independent, when he stops to enjoy the life. I think it's doable, it's achievable, and I invite you to collaborate with our center and our institute. Thank you very much indeed. And Moskalev, who is a top gerontologist, he never eats chocolate with tea. He knows that it will be product of protein that would be assumed by the wall of your vessel, and it makes, you need to get rid of this type of hydrocarbons. There are a lot of different diets, Mediterranean diet and so on. But in the blue zones, people are starving a little. When you reduce the calorie value by 30% from regular, it extends your life according to our experiment. People haven't done such kind of experiment. If it's a lifetime experiment, but in the end you get nothing. Now nobody would dare to embark on such an experiment, but you need to definitely limit easily digestible carbohydrates. Normally you should have a slight feeling of hunger, but people tend to overeat than undereat. That's one of the main geroprotectors are the drugs that mimic physical load and limit the amount of calories. And the final question from Igor Kvitnoy. Thank you very much, dear Valeria. I couldn't help asking this question. It is with great pleasure that I've listened to your lecture, and I see how I have a lot of respect towards your work as a gerontologist. In my lecture, we'll also address the issues of aging, and one of them related to melatonin. I would like to hear your opinion as a gerontologist. It's a statement of a fact that people who have survived the blockade of the Leningrad, their expectations of life is higher than in the population of those who came to Leningrad that was exposed, that experienced a siege and blockade. And these long livers who have survived blockade of Leningrad, the level of melatonin in their saliva 2 times higher, and also 5 times lower. So I would like to hear your opinion as a clinician, how melatonin, how crucial it is for extension of longevity. Melatonin is one of the top hormones, and you can use it as a geroprotector, and the more it is generated and produced, the higher it will be the longer will be the period of healthy lifestyle. It's what's proved by your works and other experiments. We even had a study where we assessed the quality of sleeping, the time, its duration, the level of melatonin, people, duration of life. So melatonin is one of those markers that you need to assess and try to influence it. And another question there was about what? I think it was a twofold question. Anything else I want to add? It was about the occurrence of yes, it was about blockade of Leningrad. It was about the siege of Leningrad. Yes, it was published in the journal, and that showed that people who have survived and experienced in the siege or blockade of Leningrad, there's a methodic hours of cells. They have a longer length of telomere. Maybe this reduced amount of calories have somehow changed their metabolism, in some or another form, in favor of protection. But you can't recommend this kind of a test because it's a super stressful. Actually, excessive stress they tend to accelerate aging. While insignificant, well, it's a distress, and it's destructive for biology. Yeah, it's a very interesting fact. Well, thank you very much, dear Olga, for your outstanding report, brilliant discussion, and we wish all your plans to come true. Thank you very much. And let us move on. Dear Valerie, dear Olga, we wholeheartedly thank you. And now, dear ladies and gentlemen, dear friends and colleagues, let us move on. But first, we want to test the equipment for our fruitful operation of the forum. So we kindly ask our guests to stay here in their seats, because both the speaker and the topic is truly interesting, and we will break for very shortly, and we will soon be back.
В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис.
Құрметті ханымдар мен мырзалар, барлықтарыңызды өз орындарыңызға жайғасуларыңызды сұраймыз. Өйткені дәл қазір біздің форум одан әрмен жалғасын табады. Дорогие друзья, просим всех занять свои места. Через несколько минут мы продолжим наш форум. Ladies and gentlemen, I would like to ask all of you, please take your seats, because after a while we will continue our forum. Thank you so much. Ну и на правах ведущего, дорогие друзья, хотелось бы также напомнить для всех наших спикеров, что у нас, наверное, к сожалению, есть временные ограничения, поэтому хотелось бы, чтобы каждый последующий спикер постарался уложиться в то временное ограничение, которое ему отведено. Спасибо.
Время пришло. Присоединяйся к новой эпохе роста.
Уважаемые дамы и господа, уважаемые дамы и господа, настал момент.
And we now move on to one of the most fascinating sections of our festival. We invite you to a breathtaking topic, which is the brain. It's the powerhouse of thought, storage of memory, but one of the least researched subjects in the medicine. So it is with great pleasure that I would like to introduce you to our next speaker. It's going to be Dr. Salim Abdulrauf, who is a renowned leader in neurosurgery. He became the pioneer also in bypassing the making a bypass and shunting on the brain. And this procedure was named after him. And I would also like to introduce you to our host, moderator, Mr. Serik Akshalakov, chairman of the board of National Center of Neurosurgery, chief supplementary neurosurgeon of Ministry of Health. And let's give a warm welcome to the speakers.
It's my honor to be here, and I'm going to share with you my experience in innovations in neurosurgery. Just want to get my slides up. Just 1 minute, please.
Дорогие друзья, просим всех наших участников форума.
So, please be seated. As you can imagine, the topic and the speaker are both fascinating.
Connected. Thank you. Sorry for those technical details, but can you get rid of this thing in the middle? This writing that's coming up. Anyway, I want to start to talk with you about a child that I met, 15 months old, that was sent to me with a very complex problem, life-threatening problem. And the next, I'm going to talk to you about my journey and then come back to this child. I want to show you how my journey led me to this little baby and the problem she had. Let's go back a few years earlier when I was confronted with this very large aneurysm in the brain of a young lady. Just so you know, in neurosurgery, most aneurysms would be the size of this little dot here. So this is a giant aneurysm in the brain. So we had to think outside the box of how to treat this aneurysm because it cannot be treated with standard clipping or coiling. So this is what's called an angiogram showing a very large aneurysm in the brain. Most aneurysms would be about this size here. So in this specific case, we have to replace the whole blood flow to the brain, close off this whole artery, and put in new blood flow to the brain, okay? So this is the journey that I'm gonna talk to you about. So the idea is we have to close off the main artery in the brain that's supplying the brain here. We have to close this off here completely and bring in a new vessel, take new vessel, connect it here, then connect it here so blood can go to the brain, and we close off the main artery to that part of the brain. This is called high flow bypass. So essentially what this is that replacing the blood flow of the brain with a new artery into the brain. When I started my career, before me, this was a new area in neurosurgery. The generation before me, there were 3 neurosurgeons who were working on this, and they were using the saphenous vein from the leg to attach to the carotid and go up to the brain here. So this was the start of what we will define on this journey that I had to take. So essentially, what we did here, we took this artery, go from the neck all the way to the brain, blood going to all the brain, and we closed the main artery to the brain, establishing new blood flow to the brain, okay? So this was one of the early experiences of using a radial artery from the arm to replace the blood flow to the brain. So how did I make the jump? When I started doing this, I scrubbed in with cardiac surgeons who were before us in doing revascularization. They're using the saphenous vein, and they're using the radial artery. And I found the radial artery size in the wall to be more similar to the arteries of the brain. So we made the switch from the saphenous of the leg to using the radial artery to supply the brain with blood. This was the beginning. So we made a transformation from the saphenous vein, which was very early experience, to the radial artery. And now the majority of neurosurgeons in the world who do this procedure are using the radial artery because we've shown that it had better outcomes. So this operation I just showed you is a very big surgery because there's a very high risk of death, mortality. It's about, from the day of diagnosis, about 40% of risk of death in the first 5 years. So we had to do a big surgery. You see, we had incision in the arm, radial artery, incision in the head, incision in the neck, and then we took the radial artery and attached it here in the brain to supply the brain with blood, and we closed the apparent artery to the brain. So now I'm looking at this, it's a very big operation. Long incision here. I started to think, is there a way to make this operation not so invasive, slightly less? So this is a lesson in innovation that I'm sharing with you here today. So how do we make this better? So as you see, the operation requires the going to the arm and taking the radial artery, long artery, then attaching it here, attaching it in the brain. So I started to think about this, and one of the things I had noticed in my early experience, there's an artery here called the internal maxillary artery. And I started to think, instead of this is a lesson for the young scientists and medical students here. You have to think outside the box to evolve the field. So I started thinking, in front of taking such a long artery, making such long incisions, why not go from the maxillary artery to here instead of going all the way from here to there? So I started thinking using this artery instead of such a long thing. That way I can have a shorter artery here and a shorter bypass instead of such a long bypass. So this was the beginning of thinking about this model. So when you look underneath the temporal area, there is artery called the maxillary artery. So my concept was, perhaps I can make the operation not so big by using this artery. So my team in the lab, we started to dissect below that temporal bone to identify the maxillary artery in cadavers. And we did a big study that was published to show what can be done with this kind of work. And we started to study this in detail. Then in surgery, we found the maxillary artery here, okay? And this is that radial artery from the arm that we took out. And now I'm attaching it here and here in the brain. Instead of going all the way down in the neck, we were able to make a short bypass. The shorter the bypass, the higher risk, the higher chance of it surviving. Long bypass, the higher risk of thrombosis. So this was the first time in a human being that this operation was done with a smaller operation to avoid the long operation going from the neck to the brain. This was thank you. This was then published as a cover page article in Neurosurgery, which is our primary journal, where we published the initial data showing how we advance the technique. From the generation before me, Dr. Spetzler who is senior to me, one of the first vascular surgeons to do bypass surgery, he's the one who named it after bypass. So now I'm honored and humbled by the fact that this is named after me in the field of neurosurgery. All this was good. Still, there was one more problem that I had to fix. We're doing these big operations, and there was one more issue that we were worried about. When we're doing a bypass to an artery, we bring in an artery, attach it here. We have to close off this artery temporarily to do this anastomosis here. When you close off a vessel in a patient, we do not know how long the patient can tolerate the closure of this vessel. During general anesthesia, we have some information from what we call monitoring, but it's not 100%. So I started to think, as we do these operations, as we've had experiences doing simpler operations with the patient awake, if we could go do these complex operations with the patient awake, we could, while we have the vessel closed here, we can test the patient awake, make sure how long they can tolerate that vessel closure. If they can tolerate it, then we can advance the technique further. So let me show you our next step, which is the final missing link in improving the outcomes. So let me take you through this procedure, how it's done. So we identify the maxillary artery that I talked to you about, that we're gonna use in this surgery, okay? And I'm gonna show you a live operation. And essentially, this is a maxillary artery. So instead of going to the neck, we're gonna go from here to here, okay? We still have to harvest the radial artery. So my team, my fellow, my residents, my partners, so we have 3 incisions in patient undergoing this surgery. This is the radial artery on the arm I just showed you. By inflating, this is the maxillary artery. I show you, I'm attaching the radial artery to the maxillary artery right here that I just showed you. This is a new technique. You see the blood coming from the maxillary artery. This is our graft. Now we have to attach it to the artery in the brain. So before we attach the artery, we check how long this can tolerate closure for the bypass. The patient is awake, and now with temporary closure, I'm asking the patient to squeeze her hand. If she can squeeze her hand, means she can tolerate closure of this artery while I'm attaching this artery right there. I'm talking to the patient. Now I attach the artery to that, and you see this is a bypass, a new form of bypass that we created. Very good. And now we close off the main vessel in the neck permanently in the patient. Permanently closing the vessel to that brain because we put a new artery to the brain. And we test the patient, temporarily closing the carotid artery, make sure our bypass is working good, okay? So we close the main vessel to the brain, squeeze the hand, check everything before I permanently close the artery. This is the first experience in the world where we are able to do awake surgery for high flow bypass to the brain. Now I know 100%, there's no risk. I know 100% the patient is gonna do well. I'm closing off the main artery to the brain here, the carotid artery, because I put in my new graft, okay? So this is slowly the progression. You see, this is a bypass. The main artery is closed. This bypass is supplying the whole brain with blood here. So we completely changed the blood flow to the brain in this patient and cured the aneurysm. So we looked at this data. This is all published data of our awake surgery compared to big centers around the world with doing this kind of operations from major centers around the world. These outcomes are a lot better than the standard technique, showing as we advance the technique, the outcomes of the patients are getting better. And we have an undergoing study right now with multiple centers looking for complex aneurysms of the brain under general anesthesia versus awake. you see the risk decreases big way, going from the standard technique to the new technique for bypass surgery that we're doing. The outcome has improved significantly for these patients. That takes me back to the little baby that we started this talk with. This is a baby in the United States that the pediatric neurosurgeons called me about in Boston. This baby was seen in the hospital in Boston. This poor baby has a very difficult problem, okay? This brings me on the journey at the end of this talk to tell you what the problem with this baby is, with her mom, and what I had to deal with. This baby, I'm going to explain to you what the issue here is. She has an aneurysm in the brain, but it's not a regular aneurysm. And I'll tell you why and why this was a significant issue. I'll explain it to you first, then I will show you what we had to do here. As this is the angiogram of the brain showing the blood vessels. Okay, let me explain this. Looks very complicated, but I'm going to explain it to you very well. This is a normal side. This is the abnormal side of the brain. This is a front. This is a back. Okay? This is the right side. This is the left side. Let's look at the normal side. Essentially, the blood is going to the brain nicely, to the whole brain, supplying the brain blood through this main artery here. On the abnormal side, you form this aneurysm. Then the vessels supplying the brain are coming from the aneurysm. So if we do the standard treatment where we clip the aneurysm, we put a clip here, we close off the blood flow to the brain, to the whole brain here. The baby will not survive that. If we do endovascular treatment, we put coils inside this aneurysm, it will close off the blood flow to the brain, the baby will not survive that. Because the main vessels to the brain are coming from the aneurysm itself. So this is why the neurosurgeons called me, said, what can we do here in this situation? This aneurysm doubled the size in 6 months, meaning she will die from it soon if something is not done. So this was a complicated problem. We have to somehow bring blood to this and bring blood to this, then close this artery. High flow bypass in a 15-month-old baby. When I faced this problem, I called two of the generation before me, biggest neurosurgeons who had done bypass surgery. And I called them, I said, 15-month-old with this problem. Both of them told me, we have never operated on a 15-month-old with a high flow bypass. So this has never been done at this age. So I was facing a very difficult problem, and I decided to do what I know I have done, which is using the artery I just talked to you about. This is this maxillary artery that the technique I developed. So I thought about bringing this artery, the maxillary artery here, attach the side of it to this artery, and then take the end of it and attach it to this artery. The idea being that the blood will go this way, will go this way, will go this way, and then through this artery go to the brain, and then through this will go to the brain here. So if I can do this and this, attach here and here, I can go in and completely close off this artery here in the brain. We never close off an artery like this in the brain in a human being, but I had to bypass it to create new blood flow into the dominant hemisphere in this 15-month-old baby, okay? So that was the idea, had never been done before, okay? So let's go through this process together. This is the maxillary artery that I use, the technique I developed below the brain, okay? That's her maxillary artery, baby maxillary artery in a brain that I'm gonna use in this situation, okay? Now, what am I gonna do here? So let me explain this. So that big aneurysm is sitting here. is sending a vessel like this and a vessel like this to the brain. Okay? This is a big aneurysm sitting here. So I decided to bring in my maxillary artery from outside here. Attach it right there. Then bring it this way. Attach it here. So the blood from the maxillary artery would go this way, this way, this way, go to the brain this way, and then go here and go to the brain this way. If I can bring in blood flow to both of these vessels, I can go ahead and close off this whole artery, the original artery in our brain. Okay, so here I am attaching, and this 15-month-old baby from my artery, the maxillary artery, they call the Abdroff artery now in neurosurgery, okay? I'm gonna attach this to this side here. I'm using a suture that's 11-0. This suture is not visible by the naked eye. It can only be seen under the microscope. You cannot see the suture. That's how small it is. This is my challenge to the young medical students here. What I talked about earlier this morning, you choose to be exceptional, not mediocre. You choose to be a virtuoso, not average. You push yourself to do things like this to, in a baby like this. So we are attaching this to this. And then and then attach the end to the top artery, to both arteries now, okay? And this is the aneurysm, and I close off the main vessel to the brain, the middle cerebral artery, to the whole left side of the brain in a 15-month-old baby, hoping and praying in my heart that my 2 bypasses are gonna supply her brain. If this goes wrong, she would not survive. She would die within hours if this doesn't work, okay? So I'm closing it off, the main artery to the brain here, and showing my angiogram that now there is flow to the brain. This is her 2 days later in my office. She got to know my baby boy, Romeo. She became friends with him. Her mother, when I operated on her, was pregnant, 6 months pregnant. So this is, they stay in touch with me. This is her baby sister who was born. She is growing up. She wants to be a doctor. She has baby boy Romeo, doll. Her mother sent me this. She did this exercise fastest in her class among all the students her age group, meaning the girl that we changed the whole blood flow to the dominant brain was the best in her class in finishing up the map of the United States. She is the youngest, thank you. She is the youngest human in the world to ever have had a double bypass surgery to the brain. I went to Boston a year ago. She drew this for me, and I'm very proud of her. And she wants to become a neurosurgeon when she grows up. So not only we do this, but we teach the world. This is us teaching in labs neurosurgeons from around the world. So we impact patients around the world. I always say, when you go and teach someone something, and you teach them a technique, and someday that helps them save a life, I have touched a life I never met. There is no better honor in the world to touch a life of a human being that you have never met because you taught someone something and they got better because of it. That is a privilege. That is the honor that we hold. Very much.
Ladies and gentlemen, I'd like to invite the moderator of this session, Serek Akshulakov, who is the chairman of the board of the Joint Stock Company National Center for Neurosurgery. Welcome. Let's give a round of applause to our distinguished guest. Thank you. Dear participants of the conference, Dear colleagues, well, a human brain is a main organ of our central nervous system that controls different functions of the human body. Hippocrates, at one point, said that brain has a power, and it's one of the most difficult, of the most serious, and at the same time, the more perfect phenomenon in nature. We the more with the newest technologies, the newest neurovisualization, neuroland, the pre-concept preparation was by our helps us restore different functions, helps restore different functions, and helps us to save life of our patient. And just Professor Salima once again contribution. And I would like to thank you for what you said, which is one of the things that I said. We read about the 10th World Congress of News. We'll invite your society here to Astana. I just want to give an example to you and tell about how a brain can control or return the object.
The operation is done awake. And here's a speaker, a young woman who was sick for many years, speech disorder. We examined her and did an operation. We received her consent. You're going to hear. And, just. So, let me fill the time. So, this patient had a tumor in the speech zone, in the part of the brain that's responsible for speech. So, can you call us the days of the week? Once again. Can you name the days of the week, okay? Can you please answer our questions? Is she answering? Yes, she is. Is she responding? Yes. How old are you? 53 years old. How are you feeling? I'm doing okay. Can you hear me? I can hear you, yes. Thank you. Wow, that's great news. I couldn't speak because I forgot my all words. The tumor got bigger and bigger, and I would eventually die one day. So they saved me. Her speech came back during the operation. I can walk better. Thank you very much indeed. I feel like we will see a lot of secrets about the brain function and the brain performance that unfortunately have no answer today. It's just a matter of the future that we will try to decode these secrets. The science will have the upper hand. Many secrets will be unveiled. We have a lot of students of medical university, and it should be a great, inspiring lesson for all of you. Thank you. Okay, let's give a round of applause to our outstanding speakers for this inspiring conversation. So, on this note, we would like to break for lunch, and we are waiting for all of you at 2 p.m. in the same room to continue our productive work. So, enjoy your lunch, and until then.
Глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в 3-м поколении. Приглашается учитель физики из города, преподаватель математики в старших классах и среднем звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, диетолог из Караганды.
The prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching
The most
profession.
coveted and high-profile teaching excellence awards.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery, and follow the progress of your treatment, even remotely. Artificial intelligence, based on deep business process analytics, helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation, and education. Traditionally,
The role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста. Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в 3-м поколении. Приглашается учитель физики из города, преподаватель математики в старших классах и среднем звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, диетолог из Караганды.
The prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching
The
profession.
most coveted and high-profile teaching excellence awards.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery, and follow the progress of your treatment even remotely. Artificial intelligence, based on deep business process analytics, helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups, as well as through a mobile app for patients. Managed.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation, and education. Traditionally, the Iraq
The role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives because teachers always
Құрметті ханымдар мен мырзалар, құрметті форум қатысушылары, барлықтарыңызды басты залға өтіп, өз орындарыңызға жайғасуларыңызды сұраймыз. Уважаемые дамы и господа, участники форума, просим всех пройти в основной зал и занять свои места. Через несколько минут мы начнем вторую часть нашего форума. Dear ladies and gentlemen, please come inside and take your seats. After a while, we will start the second part of our event. Thank you.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Айдын Рахимбаев, Нурлан Смагулов и глобальные члены YPO. Не упустите масштабный нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Құрметті ханымдар мен мырзалар және форум қатысушылары, барлықтарыңызды тағы мәрте бастапқы залға өтіп, өз орындарыңызға жайғасуларыңызды сұраймыз. Уважаемые дамы и господа, участники форума, просим всех пройти в основной зал и занять свои места. Через несколько минут мы начнем вторую часть нашего форума. Dear ladies and gentlemen, one more time announcement. Please come inside of main hall and take your seats. After several minutes, we will start second part of our forum. Thank you.
Национальная премия «Учитель Казахстана» способствует повышению престижа и статуса педагогов в нашем обществе. Встречайте, учитель химии из города, преподаватель русского языка и литературы, педагог в 3-м поколении. Приглашается учитель физики из города, преподаватель математики в старших классах и среднем звене, учитель младших классов из Павлодара, учитель начальных классов, логопед, диетолог из Караганды.
The Global Teaching Prize.
The prestigious award is considered the Nobel for educators. This is the Nobel for teachers.
The prize for teaching excellence.
$1 million prize recognizing an outstanding contribution to the teaching
The
profession.
most coveted, high-profile teaching excellence awards.
Вы открываете детям мир и миру их талант. Вы помогаете обрести веру в себя и указываете верную дорогу. И даже когда вы преподаете алгебру или химию, на самом деле вы учите гораздо большему.
Today, clients can take care of their health by booking and paying for doctor's appointments using their smartphones. Doctors can monitor your recovery and follow the progress of your treatment even remotely. Artificial intelligence based on deep business process analytics helps the chief medical officer manage the medical center transparently and efficiently. Online management provides you with more data to make the right decisions that enhance employee efficiency, performance, and overall revenue, and track the dynamics of recovery. The system tracks your health status by itself, reminding you of treatments, doctor's visits, and additional checkups. It helps doctors respond to changes in a timely manner, change treatment schedules, and follow the progress of your recovery. This reality is available today through a web-based platform for doctors and hospitals, as well as through a mobile app for patients. MedData AI, a cutting-edge AI-powered system for transparent medical center management.
Лучшие учителя мира прилетели в Астану. В столице стартовал первый саммит.
It should be noted that this year it aims to unite the world of science, innovation, and education. Traditionally, the Iraq.
The role of education has never been more critical. We must adopt, innovate, and inspire in equal measures.
And I love that the Kazakh teachers are so flexible and that they're so receptive to new ideas.
Believe in your ability to change their lives because teachers always matter.
Добро пожаловать на глобальный бизнес-форум New Vision 2024. В самом центре Евразии, в городе Алматы, мы объединяем мировых лидеров бизнеса и инноваций. 10 тысяч участников и признанные спикеры со всего мира объединятся вместе, чтобы обсудить мегатренды будущего и новые возможности роста. Алан Пис, Ричард Брэнсон, Джефф Хоффман, Брайан Трейси, Салим Исмаил, а также лидеры бизнеса Тимур Турлов, Эдин Рахимбаев, Нурлан Смагулов, нетворкинг, глобальные возможности и стратегии развития, которые изменят ваш бизнес и карьеру. 28-29 июня, город Алматы. New Vision – это ваш новый масштаб развития. Время пришло. Присоединяйся к новой эпохе роста.
Тағы бір мәрте қайырлы күн, құрметті ханымдар мен мырзалар, құрметті форум қатысушылары.
Good afternoon, distinguished ladies and gentlemen. Welcome to the second part of our forum. Welcome back. And now we move to the next speaker, and it's going to be about signal molecules. We will take a deep dive into molecular biology, and we will find out how the modern science targets diseases and different processes. Let's give a warm welcome to Igor Kvetnov, honored scientist of the Russian Federation, Doctor of Medical Sciences, a major specialist in the field of general and molecular pathology, and it's going to be moderated by Valery Benberin. Thank you very much indeed, and I'm really pleased to speak in this wonderful audience and to take you through the signal molecules and play the symphony of life. And this way they are regulating process of all process of life that take place in a body of a human being. I'm presenting on behalf of a few authors, academician Ms. Popaltsev from Moscow, and Honorable Valery Benberin, and Pulmonology Center Director Piotr Yablonsky. He failed to come, he couldn't come, but he passes on his best regards. You know that at the interface of 20th and 21st century, we witnessed a revolution, and it gave an opportunity for biomedicine to study different life processes, not only at tissue, organ, and cell level, but at sub-cell level. The there are different research methods like laser fluorescent microscopy, scanning, hybridization, and so forth and so on. It's a long, long list, and I can go on for quite a while. And a new dimension medicine emerged. It's called molecular, something in English they call it biomedicine, and it's a new innovative area of medical science that is based on personified approach. We need to treat not a disease but a particular patient, and in order to treat successfully this particular patient we need to know his metabolic status, his genome, so to do a proper molecular diagnostics, to make sure, like it was said in the title of the lecture, to make this therapy targeted, so that the disease would be affected and the drug will go to this sick cell and not affect systemically, and not to violate Hippocrates principle, not to harm. And the key, a vital role in diagnostics and molecular law or biomedicine, that is called translationary, because it translates the results of fundamental studies into clinic, is played by signal molecules, which can act both as markers of specific diseases and as targets of therapeutic action. So they give a signal to the target how it needs to respond to a hormone or to other active product. And since they participate in regular life mechanism, so they participate also in the development mechanism of certain diseases. And since they participate in the development process, development mechanism, they can act as markers. So you can measure it in salina, in spinal fluid, in urine, and so on. Because by leveling it up, you can even either prevent or treat it successfully or play down certain symptoms. Because on the one hand they act as markers, but on the other they are a target. And it's my favorite example that I'm going to come back to. If phospholipid tau protein at Alzheimer's disease, if we imagine if we can phosphorylate it and make it ordinate, then we will get rid of Alzheimer's disease. It's a fantasy, but we know the molecule here that we need to target, that we need to impact, and the science moves forward. In the past, these signal molecules that would be generated by cell and be detected in biological liquids. Now, this secretion of these molecules can be measured not in the cell itself, but also in the cell organella. Here is a list of markers, the list of the signal markers that is produced by certain organoids. Using mitochondria, there are around 10 proteins of the membrane that participate not only in synthesis and in the decay of energy. I will tell you about it in the next lecture that Olga Tkacheva has told us about. This spectrum of signal of mitochondrial proteins, the expression of which is deviated, is identical in disease also, as well as in coronavirus. Let me tell you more about melatonin. I will give you an example how you can optimize diagnostic and treatment opportunities. Let's take melatonin. As you know, melatonin was first discovered in 1958 by this person whom you see in this picture. It's It's not a molecular biologist, not morphologist, not physiologist, but dermatologist, Ron Lerner. In 1958, he found this melatonin in the pineal gland, went on pursuing this goal, and in 4 years has won the Nobel Prize. And he was practicing in a clinic not far from Hollywood. And since he was a known dermatologist and people would come to see him, some famous actresses from Hollywood who wanted to play young ladies, and some plastic surgery would enable them to do so. However, getting rid of this pigmentation on their hands was not possible, and they were begging him to come up with some cream or ointment to get rid of these spots on their hands, because they can do plastic surgery on the neck or face, and they can still be play young characters in the movies. So yeah, he read a lot, and he found an article. So 40 years before the discovery, two Canadian researchers, McCourt and McCallan, have published in the Canadian Journal an article, and they received the Nobel award back then. You know, they're giving for some research and discoveries that at first glance seem to be stupid or unnecessary or paradox. So what did McCourt and McCallan do? They collected at slaughterhouse 800 pieces of cattle, grinded it in dry powder, and fed small frogs with this food. However, this frog larva who couldn't avoid and ate this powder, in 4 hours they switched from dark green to light gray color. And McCourt McCallan has detected it, published, and forgot about it, and received the Nobel Award. Well, Lerner has encountered this article and thought, what if I gather not 800 but 2.5 thousand, which he did. But he didn't grind it into a powder, but made extract and put it into lymphatic bladder of a frog and create a powder or ointment that removes pigmentation, and he did so. And those small frog larvae who received this powder would also switch the color, but that was 1958, and he worked at Yale University, and he had a friend. They did a chromatography. They extracted unknown substance, unknown product that was at the last phase of all predecessors that created from serotonin, and they called it melatonin. When they were receiving the award in 1958, in the lecture, Lerner wrote, "I choose melatonin because this makes brighter." And later on, this goes ahead further, and great experiments were done by Gartner, who established that at full extirpation of pineal gland in experimental animals, the number of melatonin remains in blood, and there's a large number of melatonin is identified in bowel and stomach. My colleague first read it in 1972 when I came to him to give me some topic for my thesis. He told me, "You work as pathologist, you have a lot of enterochromaffin spammer cells. They produce serotonin, they do. And serotonin is a predecessor of melatonin. The number of melatonin after extirpation of pineal gland in the stomach and bowel remains there. So find it, you won't get a Nobel Prize, but for the entire life you will get an interesting problem. In 1975, we injected this acetone substance to the frogs, to the appendix, and we showed that in the gastric tract there was a lot of melatonin content, and we called it extrapyramidal melatonin. We didn't win a Nobel Prize, but I won the awards of Lenin Komsomol in the Soviet times. That was good enough. It was maybe even more important than Nobel Prize for Soviet person. My wife is sitting here, Professor Tatiana Bevnaya, and you can find her data in the priority study. The total cohort is not exceeded. She did with German colleagues from a university. The cohort was 1,172. That was possible only at Cancer Center Blokhin and Radiological Center in Obminsk. We brought it all frozen in on the plane in liquid nitrogen. Can you believe what we've done? It's a separate. We use another person's passport and credentials. However, it's a different story. But we've done this study in Germany, in Tübingen, with our doctors, Christian and Hellebucks. So what have we done? At first, we were disappointed. We thought that melatonin could be a diagnostic marker on the telling about presence or absence of cancer tumor. It's not, because the concentration of melatonin it was extracted in the early morning. So the blood of a patient should be taken at 2 a.m. because melatonin has certain dependency. It turned out the change in secretion of melatonin in oncology patient depends on organic localization of tumor. 2, and thyroid gland. 4, which is almost double in case of a ovarian cancer. It's hard to tell whether there is a tumor or not. But if it's already there, then progress and the forecast of the tumor could be well measured at 6-sulfate melatonin, because there is a positive correlation between the excretion of this metabolite and proliferative index of a malicious tumor. Malignant tumor can be seen as non-invasive informative marker to assess the progress of tumor. A person can go and pee a few times a day. It's not as difficult as that. If you have money, you can buy sufficient number of kits for immunoferment analysis of 6-sulfate sulfate. We can do it as frequent as 5 times a day to tell his concentration. 5 times a day is too frequent. However, through the entire course of the treatment with a non-invasive method, you can tell how effective that treatment is. Here is the picture that I asked Olga about Leningrad's blockade. The frequency of oncology in children who survived the blockade, who are now elderly people, is lower, and melatonin is almost double the level of regular population. That was published in Lancet journal and other popular journals abroad. We even received Edinburgh Oncology Society grant to continue this later on, and excessive amount of melatonin in saline tells us about oncology resistance of that particular person. So melatonin, being multifunctional signal molecule, can be seen as a promising marker and a target for targeted personalized treatment and diagnosis of second moment. is development of the panel of molecular markers and endometrial implantation susceptibility. If in this period blastastat is possible to invade, then you can forecast success of the pregnancy. Women are coming to artificial fertilization, and they don't know whether that will happen or not. We have analyzed around 27 signal molecules. We have extracted 2 of them. That is leukemia that inhibits and transforms the factors of growth. Because they are the ones, in 70–80%, they ensure the possibility of endometrium that blastocyst can host.
So if prior to IVF we carry out the analysis and see such a picture, and the microscopy gives us a chance to identify the area of expression, then we can forecast the positive result of the extracorporeal fertilization. If the picture looks like this and it is quite visible by color, the area of expression of these markers is quite visible, then we can forecast the negative success of the extracorporeal fertilization. And we see the integral marker of the chronic endometriosis, and therefore we need to first identify the remission condition and only then get to IVF. And next example of the molecular microscopy includes the optimization of the target diagnostics and treatment of the socially significant diseases of the respiratory system. And the signal molecules can be expressed by different means. They produce lots of signal molecules which can fulfill different functions, starting with the cell proliferation and finishing by cell aging, as well as the remodulation of the pulmonary tissue. And here you can see the examples of the laser microscopy, and at early stages of pregnancy, at early stages of pregnancy, it is the signal molecules are produced, and they are actually responsible for the regulation of different processes of a human's livelihood. It is possible to carry out the scanning of such cells in order to see the ultrastructural scanning tomography of cellular organelles in the alveolar macrophage, with the subsequent transformation into a holographic image. That's when you can actually look at what kinds of signal molecules are being generated in mitochondria. Here you see the extract from the report by Clifton Barry from the National Health Center in the United States, and we actually thought about how to increase the sensitivity of the microbacteria of tuberculosis, because in all cases of TB we see high level of resistance of the microbacteria. Therefore, with the molecule of the nitrogen oxide, and if we use the anti-TB preparation, then the oxide gets into the bacteria, explodes it from within, and that's what Professor Barry said. This is a very reactive molecule which acts as a bomb, and it explodes the microbacteria from the inside. And this is actually visual with the confocal microscopy. You can see some light here, and this green fluorescent light shows the explosion of mitochondria that is connected to the phthalate molecule, and there is the explosion, the microbacterium gets dissolved, and when it turns somewhat green, that actually shows the process of dissolution of mitochondria, and the bacteria gets destroyed. We carried out an extensive research of the diagnostically significant signal molecules that allowed us to develop the panel of markers. This is the example of the differential diagnostics, and the autopsists know that we still don't have reliable methodologies. We need to first find out whether a person has the tuberculosis or he is suffering from the sarcoidosis. And in both cases, if we see very high degree of expression, then this is the case of sarcoidosis, and if the expression degree or level is low, then it's tuberculosis. There are a number of mediators, and as it turns out, some cells play a key role in forming TB, because with such a degree of granularity, different enzymes may be formed. Well, this is what destroys the tuberculosis granuloma. Out of 22 molecules which we have studied, we've selected 7. They are marked in red. So this is how you can actually use this panel in order to carry out the differential diagnostics between sarcoidosis and tuberculosis. I will have a separate presentation on cognitive molecules, but we just wanted to show this research. This is a good source of pride for us, the development of the molecular markers in diagnosis of Alzheimer's disease. About 30 million people around the globe suffer from Alzheimer's disease. And according to WHO experts, by 2040, their number will double. So you see the picture on the top left. This is Alzheimer, who actually provide the first description of condition of Augusta Deter, his first patient. Tatiana and I worked in the same department where he actually gave this diagnosis to Augusta Deter, and we saw her medical record where Alzheimer's says non-vascular origin of dementia. And it was almost impossible to find this out at that period when there was no CT technologies available. And he unfortunately cannot answer our questions right now, but further research results proved to be right, because 2 proteins were the ones to blame. They caused actually the Alzheimer's disease. These are, for some reason, they get phosphorized, and out of useful neuroprotein, they turn into the pathological senile cells, and they disrupt the neurosynaptic transfer, and it all takes place in the hippocampus. This is the key proteins involved in the pathogenesis of AD-tau protein and amyloid in tissues and cells possible for biopsy. So it is really important to focus on development of reliable methodologies, because there are some disease cannot be considered a neuropsychological disease. It's the most. Therefore, we decided to see whether or not we can actually work with our Spanish colleagues. Back then, we were working in Valencia. And we decided to look at the lymphocytes of patients who've been diagnosed with Alzheimer's disease. And we decided to see whether or not they have tau protein expression. And 264 patients out of 272 with the clinical diagnosis of Alzheimer's disease had tau protein in their blood, whereas only with 2 cases we had some trace reaction. Well, we decided to look at the buccal epithelium, and as it turns out, it can be considered as a great biomaterial for non-invasive diagnostics, whereas tau protein and beta amyloid can be considered as highly informative marker for molecular non-invasive diagnostics of the Alzheimer's disease. We got the NATO grant together with our Spanish colleagues, and then it got extended, and Tatiana and I would go to Valencia for several years. As a result, in 2015, we included our research results into the report of the Council of Europe, where our methods were considered as 100 top developments for the treatment of social significant diseases. When we speak of non-invasive diagnostics, buccal epithelium considered a new way of non-invasive personalized molecular diagnostics of diseases. When you get the liquid cytology, you use the monolayer of cells, and this monolayer of cells can be used for any immune cytochemical reaction. Right now, we see lots of research under the state order of the Ministry of Health of the Russian Federation, under which we work on verification of markers of different socially significant diseases. And since we work in the Center of Physiology and Pulmonology, we also look at the neurodegenerative diseases, and we work with such molecule as ICAM1, because the American researchers, for example, found out that the hypergeneration of ICAM1 in saliva for 72 hours usually predefines the risk of the coronary catastrophe. So, such results testify the key role of the signal molecule, which ensure the intercellular neuroimmune communication dialogue in support of homeostasis of organism, and the diversity and high specificity of the signal molecules, or so-called biomarkers, then they determine the high importance of the development of non-invasive methods for their verification to optimize the diagnosis and targeted therapy of socially significant diseases based on the concepts of translational biomedicine and principles of 4P medicine: predict, prevent, personalize, and participate. Prediction, prevention, personalization, and patient-centered. So the biomedicine, which is considered as the modern integral area of the biomedical research, aims to increase the effectiveness of diagnosis, treatment, and prevention of diseases through the introduction of achievements of fundamental biomedical sciences into practical healthcare, and translational biomedicine develops clinical practices in the application of the basic scientific aspects. We would like to express our gratitude to our Spanish, German, Belgian colleagues with whom we've been working for a long time prior to the geopolitical situation. And hopefully we will be able to continue our cooperation. Thank you very much for your interest and for your attention. In conclusion, I kindly ask you to with the permission of my co-author, hopefully during our next lecture, we will give information on behalf of both of us. I hope that you don't mind. Then we kindly ask Valery Vasilievich the question: are we going to have a brief moderation after this lecture, or shall I get down to my second lecture? Then I kindly ask you to show my lecture number 2 on the screen, where we talk about the inflammaging and mitochondria. I would like to reiterate again that this is the lecture that I'm presenting on behalf of both of us. To make things more interesting, I just wanted to say that based on the common grounds of our scientific interests, long time ago, Tatiana Viktorovna and I had the official romance, and I was almost expelled from the Communist Party of the Soviet Union because of this romance. But as a result, things ended up well. We are happily married, and I would like to give the lecture on inflammaging and mitochondria melatonin as the metronome of aging. This is how we call it. So mitochondria indeed are not so-called unique organoids of cells, but these are those organoids which to a greater extent save the ability of the cells to function because they generate the intracellular energy, and it's been proven that they are the richest in terms of expression signaling molecules of the organoid cells, and there are even two terms. One of them is the mitochondrial diseases, and indeed those diseases that are related to the pathology of synthesis and secretion of the mitochondrial proteins. And the second term is the mitochondrial aging, because as it turns out, mitochondria are responsible for the programmed death of cells, and that is why the mitochondrial pathway that includes dysregulation of several enzymes leads to the accelerated aging of cells. And here on this slide, you can actually see what are the pathological processes which may lead to the disorganization of mitochondria. These are the mitochondrial diseases that I mentioned earlier, or the metabolical, neurological disorders. But all of these things eventually start the process which is called the inflammaging. This is the chronic inflammation process that creates the abnormal organelles that are called inflammasome that cause the death of mitochondria. But as you understand, if the power plant is shut down in a city, then the livelihood of the city residents will be disrupted. Same thing can be applied to a cell. So what's the role of melatonin here? We will see it very soon. I just wanted to quote a French philosopher, Descartes, who once wrote saying that the pineal body is the vessel of soul. Why Descartes said so, well, I don't know that, but he mentions this in his philosophical records. So the pineal body was actually quite well known during his life, and but until Lerner in 1899, no one really understood what's the point of having this body that can be extracted during the autopsy only. And as it turns out, this is a very important hormone, and I'm reiterating all of these things again. And here you can see the quote of Lerner, and he explains why he called it a melatonin. Eventually, melatonin is in charge of very important processes. First of all, this is a very unique regulator of different biorhythms in the organism of human beings and mammals. There are different types of biorhythms, and melatonin regulates our sleep. It stimulates the immune processes. It is the strongest endogenic absorbent of free radicals, and it is even more active than the glutathione, and it has the anti-tumor effects. It is indeed a very important hormone for our lives. It synthesizes from the amino acid called tryptophan. It goes through the serotonin stages, and it turns into a melatonin. It has the highest concentration of melatonin is observed at 2 a.m. in the morning. This is the you can see the images at the top and at the bottom, where you observe the highest concentration and the lowest concentration of melatonin depending on the time of the day. We also found out that in the stomach and in the intestine of the some animals, the melatonin is present. These are the guts of rats. In 1975, in Nature, we had an article published, and indeed, this is something noted in the British Encyclopedia. We are the discoverers of the extrapineal melatonin. As a result, the Austrian physiologist Hutton said that if we can calculate the number of cells in the stomach and compare them to the quantity of pineals, then extrapineal melatonin in the organism is generated 400 times faster than the pineal body. And melatonin is the cornerstone of the neuroimmune endocrinology, and the article, which was published back in 2022 in International Journal of Molecular Science, which was called Melatonin, a cornerstone of the neuroimmune endocrinology. Well, this is the very first hormone, the production of which was verified in the classical cells in the intestines, in Purkinje cells and epithelial cells. So there are different publications by different authors who proved the presence of the same hormone, which gave us a basis to offer the term neuroimmune endocrinology for the first time. But we decided to move further, and by looking at the extrapineal localization of melatonin, we found out that this localization includes the thyroid gland. And if we look at the C cells where the calcitonin is generated, and I already mentioned the lymphocytes and then natural killer cells, the localization of melatonin is quite broad. It is produced both in endocrinal and other cells.
So we state that extracorporeal melatonin plays the key role of the signal molecule in local coordination of intercell interaction. However, he cannot embrace what you can't, and he is where it all ends for the Soviet scientists. And there is a prolific American endocrinologist who is deemed to be a fan of melatonin. We did a joint work together. We espouse here in Germany and in San Antonio, United States, and Redel just did us when we came to see him to read a lecture. He was trying to feed us with this melatonin from the morning for breakfast, lunch, and dinner. He fed his horses. It was in Texas, where he owned some ranch. His wife Nancy, and he nearly wrote a novel about melatonin. I was pretty skeptical, but Barsh got so excited that he wrote an article to Spiegel, which he called melatonin madness. And after that, they had a squabble with Reiter, trying to make them friends again. However, Reiter is 100% sure that melatonin is a life hormone. If you take it, you will live a long life. If not, then he's around 90. He eats tons of melatonin, but this is all a joke, of course. However, this is life-important hormone, and what makes it unique as well, this is the only hormone molecule that penetrates not only through the membrane, but also through the nucleate membrane, through mitochondrial membrane. And he's not that crazy. Of melatonin membrane technology, and found traces of melatonin and crisp of mitochondria. Because this is why he showed the intra-organoid localization biologically active substance, and this mitochondria is gene, not melatonin in general, or pineal or gastric, but mitochondrial, because it works with autocrine. On autocrine basis. It's generated by mitochondria and includes mitochondria thanks to the presence of two receptors, alpha and beta. he amplifies the effect of antioxidant because it's a scavenge, so it protects the cell against oxidation stress, and melatonin of mitochondria launches inflammaging process. However, if there is a scarcity of, if the synthesis is dysfunctional, then there is, it can be falling all apart. You can see it on the microscope, and there are inflammasomes appearing, and it's also regulated by melatonin. And in case there is inflammasome regulation is deviating, there are some autoimmune metabolic diseases, neurodegenerative, and as well as oncological diseases. And it's a full package that is age-associated process. And this is what Olga has told us. When COVID-19 emerged and it penetrated mitochondrial membrane, and that's where it defeats mitochondrial, and that is called TOM 20 and TOM 70, and actually the generation of growth launches that very cascade cytokine reaction that results in cytokine storm. So aging and cytokine storm, they in principle they are pretty much the same on molecular level. So inflammaging, which is the cell aging, is simply a slow latent cytokine storm, and it's around 2 or 3. But under COVID, it's 2 or 3. The mitochondria become dysfunctional. Oxidation radical gets higher. Melatonin stalls at this level. Mitochondria gets exploded, and you can't help the person. And you need to save it at the chronic inflammaging stage. Claudio Francesca, former director of the former neurology center, he is honorable professor. This is cooler than a Nobel Prize winner, because there are around 2,000 of them, while honorable professors of Bologna University, there are only 87 of them. One dies, the new one doesn't get re-elected. Called inflammation and aging. Inflammaging. So we honored to know him, even to argue with him. How do you think old he is on this image? You're all wrong. He's 82. He is dancing a tango. He drinks a bottle of wine. He loves Russians, and he creates a lot of inventions. So he was studying immunocompetent cells. By his background, he is an immunologist, and he found that no matter what organ he is analyzing for immune cells, plasmatic or dendrite, or immune-competent bodies that consist fully from immune-competent cells, it turned out that when aging in culture or in old animals, these immune-competent cells generate 7 equal molecules, which he united into phenotype CAP, because he thought that this immune phenotype senescence-associated secretory phenotype. And he came up with this term, inflammaging. And indeed, many factors like environmental and endogen can cause aging of immune system. So inflammaging is progressing. Franceschi went to fantasize that inflammaging is the core reason for these multiple diseases. Just like Olga said, it's not know what is cause and what is the result. However, it's all balance of the mechanism of evolutionary determined and accelerated cellular aging and leads to development of fatal diseases unless they are prevented and treated in a targeted manner, lead to death. So it's CSP that Francesca was offered for verification to verify inflammation, and with this phenotype, this is what we were arguing about, and later we drank a bottle of red wine. I approached him, but I couldn't really ask him a question in the presence of the audience. It felt awkward. So during the coffee break, I approached him and asked him, asking that this senescence phenotype, none of the molecule is associated with the aging. How does this work? You don't have melatonin and santonin, you don't have clotagen. Why are you saying that this phenotype reflects aging? Maybe it doesn't. So Franceschi got infuriated. You're an immune chemist, so take care of that. And if it works out, we will come back to this conversation. So I went back to the laboratory. I had a PhD student who was looking for some topic. I asked her, is it possible to include some marker molecules that would reflect, so to expand this secretory phenotype that should prove his concept right and not prove it wrong. So it's not our invention, but there are a lot of studies that under IV irradiation show that under experimental inflammation we see higher expression of pro-inflammatory proteins as well as proteins associated with aging. And the expression of endogen geroprotectors CT1, CT6 is going down, such as carnitine and IL-8. So the phenotype that was determined by Francesca could be expanded by including those molecules that I told you about. So we printed this article, we sent it to Francesca, asked him to be a reviewer, and we need to give him the credit. Said thank you, that's truly interesting. Recommended to be for further publishment in an interesting journal. We received a joint grant with Francesco for the follow-up studies. However, the geopolitical situation interfered with it. The grant was issued by Italian and Russian foundation, but it was suspended. And now a little bit more about our experiments that tell us more about the role of melatonin. We took two groups of rats, young and old. These rats were injected melatonin, and we were measuring a panel of 10 mitochondrial markers. So we tried to associate, to see the association with mitochondrial pathology. At the bottom, you can read it almost word by word. A group of animals senior age presents interest for the study of melatonin as a possible target drug for prevention of coronavirus infection and both for geroprotective drug. Because at older age, rats are posting inflammaging processes. It's chronical immune, and at large they are comparable to the process in COVID-19. And a target here is mitochondria again, for that is organoid target. And then we describe the impact of the virus on mitochondrial membrane. Mitochondrial protein is the target for coronavirus, so taking into account these circumstances, the target effect of melatonin will be achieved by regulation of expression of mitochondrial protein. So for further microscopic analysis, we took the heart and liver as the tissues of those bodies that is rich in mitochondria, but we retain all the organs. We studied 7 mitochondrial hearts by confocal fluorescent with digital microscopy to calculate the area of expression and comparative brightness. On this and follow-up slides, there is a pathogenic preconditions for the effect of melatonin and what proteins are responsible for what. Pink one is protein that launches mitophagia processes that regulates the further protein. Mitophagia is the death. This is a cytokine storm that shows that infomosomes are losing it, and by killing mitochondria and dysregulation of mitochondrial proteins, cytokine storm evolves. This is prohibitin that suppresses DNA synthesis. It was also studied. And now let's have a quick look at these pictures. What you see in a confocal microscope on the right is a graphical image of the expression area that is being a quantitative method of the study. I would like to leave it and it's mitochondrial proteins, confocal microscopy. She did was by treatment means injection of melatonin, expression of such factor of DRP1 in myocardium. You see the control and you see the treatment, injection of melatonin and melatonin in control among increase in expression of this protein. The same is true for the liver tissue. Here is the expression of this Parkin protein that is responsible for well, when aging, this protein goes down, but however, the injection helps us not only to bring it to control and even increases its expression several-fold. The same is true for the liver tissue. And just accidentally, we bumped into melatonin deterioration of lipofuscin. So it has not only anti-pigmentation spots. All the senior age people know this pigmentation. It's not melanin. Just again to make it fun, we have a staff member. Her mother is biochemist, and the daughter is doing her bachelor thesis. And mother, she's really interested in what she's doing, and she said, "I wonder this melatonin. If I apply this pigmentation spot." So I applied it with melatonin, and in 30 minutes, she showed no H pigment. So they did a myocardial study and the immunofluorescence of this H pigment. I think it's 7 times lower. Does it matter? Yes, it does, because cardiosurgeon is saying if the patient was giving some drug that blocks synthesis of H pigment, then restenosis percentage, that it was a study done with experimental animals, then the percentage of restenosis goes down twofold. This is in myocardium and in the heart, and this is in the liver tissue, and this is in the myocardium. It's integral map for all markers. It shows that under the effect of the synthesis of myocardium. So therefore, the studies show that melatonin is a metronome of aging. It tunes the cells for rhythmic operation. So increased aging leads to the cell aging slows down, and you can deem it as an endogen geroprotector. However, molecular targets, these are mitochondrial proteins. Melatonin is a signal molecule that strengthens the functions. It is a molecule that steps up function of mitochondria. This is corona infection and other comorbid conditions. So thank you very much for your attention. Ladies and gentlemen, and now we give the floor to Valery Benberin once again. Let's welcome him on the stage.
Dear colleagues, we just listened to two lectures in the field of fundamental medicine. A brilliant lecturer, a brilliant scientist, a world-class scientist, a pioneer, and someone who has been studying the structural components and the root causes of the emergence of pathological conditions and diseases. He finds different pathways of treatment in practical medicine. Igor Moiseyevich is the renowned, recognized scientist, and during his scientific activity, he got the award of the Elizabeth II, the former Queen of the Great Britain, and a lot of people refer to his research, to his works. So Igor Moiseyevich, signal molecules, small or big, they are both markers and targets. So they give the opportunity for further production of different target therapies of socially significant diseases. Yes, and that's what I was talking about, because the synthesis and secretion of these molecules tend to change in the process of development of one or another disease by measuring their level in available biological liquids. It makes it possible to, first of all, trace the development of the disease, make projections about the outcomes of the disease, because they can be both targets which can be affected by pharmaceuticals. So by synthesizing and the evolutionary determined level that must be on a normal level among normal human beings, it is possible to either prevent the development of such a pathology or to seriously optimize its treatment. And on the basis of this research, the development of different diagnostic panels takes place. And this development is quite successful. We spared no efforts to make it possible. This is a sign of pride to me personally. We've completed the research, which was financed by one very large company in the field of AI development and communications, and they wanted to invest some of their revenues into the socially significant research, and the country needs to know its heroes. This company is called the Maxima Telecom, which supplied of this company once was asked the question, well, until the president gives his New Year's speech, I'm not able to go to any vacation. So lots of financing into our project. And three signal molecules and one panel makes it possible to determine the presence of clinically not expressed cognitive disorders. So we had the group of neuropsychologists who took tests in order to define or determine the risks of cognitive disorders. So a sufficient number of people the same age that we attracted to this study, and I'm talking about the faculty members of the universities or even designers, the submarines, they don't have any cognitive disorders, seemingly, but the psychological tests showed that there is something to think about and to pay attention to. Therefore, eventually, with the panel which we've developed, we determined tau protein and alpha-synuclein, and those people who had no clinical dementia but had some indicators either on the upper margin or above the upper margin, this proved to be the most important method for screenings. And I'm talking about the dementia diagnosis. We were supposed to develop the live panel, not the post-mortem panel, the live panel. And we developed two panels. The first one is the panel that I'm talking about, whereas the second panel is when it's proven that the patient has dementia. So when you have the set of markers, you can say that this is the dementia caused by Alzheimer's disease or the arteriosclerosis or intrabrain arteria or the Parkinson's disease. Therefore, such pathologies demonstrate different quantities of expression. I cannot really say a lot because we have applied to the patent and now it's undergoing some expertise. But once we get a patent and publish the results, I believe that, well, you will see the entire use of these studies. In this regard, it would be nice to get more detailed information about the following. When there is a high concentration of melatonin in the buccal epithelius, it helps determine the resistance to oncological diseases. And I think that this is a good discovery. As for melatonin, I think that we can keep talking about it because this is the merits to be given to Tatiana Viktorovna because it was her grant and only she could bring together thousands of people and work with them days and nights. But this is another story to tell, and maybe someday she'll share this story. But the global community appreciated this. And Tatiana Viktorovna with Parsh couple back in 1998 received Gardner Award. And I wish she got the Servier Award from the international pharmaceutical company that subsidizes the hormone-related researches. So, well, melatonin as the prognostic molecule during oncological diseases is used quite broadly abroad. It is not so common in Russia, though, but in Germany, in the clinic where Barsh couple works, the patients that this clinic accepts, and this is the clinic for the female reproductive system treatment, all of the female patients with different types of cervix cancer and so on and so forth use the same methods, but we haven't patented them yet here. So once our results are published, we will be able to say that we sent a few letters to the Ministry of Healthcare of the Russian Federation with the to anything specific. What about the melatonin that has pleiotropic features and its interaction with other modulators? We haven't had such studies, and I am very cautious about vitamin D. I am not a proponent of Professor Kalinchenko's opinion, who says that large dosage of vitamin D shall be consumed by people. He even has the group of doctors that call them doctors D. So It occurred to me just now that the synthesis and metabolism of vitamin D can be fraught with ultraviolet, and melatonin dissolves in the light time of the day. But it would be quite interesting to look at such studies. Melatonin may serve as a cofactor which can contribute to the treatment properties of vitamin D. Then I have one more question. Well, in the mass media, particularly in certain clinics, they recommend using vitamin D in big dosages, which enhances some other unfavorable processes, including the oncogenesis, when, for example, the intracellular melatonin goes up and we cannot really measure it. That's I'm talking about 120 international units. I mean, such dosage can be quite dangerous. Again, I'd like to reiterate it once again. It is something interesting to take into account, but I cannot say anything specific about that. Well, molecules, big or small. Well, there are signal pathways, which you also studied, right? Could you please provide more info? We've studied only those pathways that are related to the molecules which are of interest to us, and we are still continuing the cycle of studies on the extrapineal sources of melatonin, and we want to launch such a study for sarcin protein. It's not a very well-known protein, but the group of Italian professors led by Mozaccoli demonstrated that the hyperproduction of such protein in malignant tumors helps determine their multiple medication resistance. So cancer cells become more sensitive to chemotherapy if we use this protein called sarcin. And it was demonstrated in the lungs carcinoma by Lewis and in a number of different experimental studies. And we want to look at the biopsy or the operation material among those patients who get surgery for lungs cancer or TB. And according to Davidovsky, TB prepares the grounds for cancer. And in 15% of TB patients, we see the emergence of malignant tumors, and the treatment with medication is less effective here. Therefore, it is the anti-TB treatment becomes less effective as well. So we want to see that sarcin protein with regards to cancer. This is the calcium modulating protein, and we will look at the signal chain of calcium channels, and we believe that this is something that could be quite a promising vector of study if we actually see how we can modulate the resistance to medication by using such the molecule. That's quite interesting. In your lecture, you also highlighted the influence of melatonin on sirtuins, the expression of which reduces the possibility for cancer. How does it interact with mTOR1 complex? Have you studied this? I'm a bit confused. Oh, well. So I have a question to the audience. This lecture was very interesting, and I believe that you have a lot of questions. I see a lot of hands raised. So, volunteers, could you please pass the microphones? Good afternoon. Thank you very much for your lecture. As a microbiologist, I'm curious, have you studied the effect of melatonin on microbiome? Because there are some studies that show that the microbiomes synthesize serotonin as the it is important to know about your opinion on how melatonin is connected to the intestine microbiome. And what comes first? Does melatonin affect obesity or vice versa? And how does it affect the production of melatonin? Well, I suggest that we turn up the lights in the room. In that case, I think it'll be more convenient to answer your questions. You know, I love studying what I know and what I understand. And apart from the definition of melatonin that I can share with students, I know nothing. I'm not a microbiologist, I'm not an immunologist, I'm not the bacterium specialist, and I'm not a specialist in microbiota. I've read some works that show that a number of bacteria develop or generate serotonin and melatonin, and I'm sure that 15% of our intestine melatonin are consisting of bacteria, but I've never studied influence of melatonin on the functional condition or state of microbiota, and I've never studied the processes of obesity. I've never had such a purpose. Tatiana Viktorovna studied melatonin as the prognostic test in the metabolic syndrome, but that's a different story. And Dr. Andropov, in particular, focused on melatonin, but mostly in order to develop the diagnostic indicators of the climacteric and metabolic syndromes in the mechanisms of obesity, and with the participation of, well, we've never focused on microbiota. Therefore, I'm quite grateful to you, because it means that you had a hope that I can answer this question, but unfortunately I cannot. But this is a good, promising area for future cooperation, undoubtedly, and we are ready to cooperate. We are ready for cooperation, but again, we are used to cooperating in those areas where we understand certain things and we can do certain things. Unfortunately, we do not really understand much about microbiota, and there is a little that we can do in this regard. Thank you. Today, you mentioned a very interesting information. I am in extraendovascular surgery and I've been here for 15 years. I implant stents. And for the time being, what do we see? There are some balloons with the special surface which destroy cells that cause retinostent. And today it was said that melatonin has a property, a destructive property in the myocardium of the, and that's the area where we mostly put stents. Can you tell us, can we hope for a melatonin to become some preventive medication prior to stenting coronary arteria among high-risk patients or among patients who have multivascular damages? You know, you're asking the question that can be characterized as, don't make my pain bigger. Together with Professor Timmermans from the University of Antwerp, where he has this great laboratory where he uses guinea pigs in order to learn more about different stents. Together with other cardiovascular surgeons, he has this molecular microscopy laboratory, and we're actually very proud to see that we have the panel since with 95 markers in our refrigerators. Let's say when Professor Timmermans has the panel of 400 markers. We barely have one confocal microscope for 3 laboratories in the Institute of Otobel, whereas Timmermans has 3 microscopes in 1 laboratory, and they held a very interesting study there in the laboratory to develop the surfaces or the coverage of the medication that can be covering the stents when the rabbits' arteria are treated. And we even received a grant from the National Council of Belgium. But again, due to the current political situation, this work got suspended. Anyways, I can get you in touch with Professor Timmermans. He is quite an interesting person. We can join the conversation between you and him. So I remember that xerolixone was added, melatonin was added to it, and the restenosa index was much lower among those rabbits that had the stent instead of the stents with sirolimus or other substances in other rabbits' stents. But this is the fantastic result, and it gives us great hope. So if we resolve the problem of the stent restenosis, then we will be able to see great successes in the internalized cardiology that will help us take over the ischemic diseases of heart. This is the new area in the internalized cardiology, and I'm not an optimist. I know that we will be able to somewhat resolve the problem with restenosis, but we can even reduce the percentage rate of this disease from well, this is quite possible. And in addition to melatonin, it is also possible to use other signal molecules. And maybe they, well, this is something just to work with on a permanent basis if we want to get some specific results. Thank you.
Well, good afternoon, dear Igor. Thank you very much for your wonderful lecture. To sum up your lecture, in conclusion, I would like to ask a basic question. In order to get rid of jet lag syndrome in Russia, they sell melatonin by 3 milligrams. In Europe, it's only 1 milligram. In US, it's up to 10 milligrams. And to sum up your conclusions, maybe we can say that melatonin is a drug to extend life. Maybe it should be consumed in the for prevention. To take up your question, the first time I flew to a radar professor in San Antonio, I didn't take melatonin. I came barely alive, and he told me, "You open extra opinion on melatonin." When he sent me back, he gave me the 3 milligram pill, 30 minutes at JFK airport, and say, "You will take another one mid-flight." And then, having arrived in Moscow, we used to live in Obninsk, "You will take another half pill." Tatiana will help me stay honest. I just told her we didn't need to go there, and I fell down asleep. So, but there were no consequences. And ever since then, indeed, when we flew to Kazakhstan, we bought Milaxan. It's a 3 milligram dose, but we break it into 2 because I feel that 3 milligram is a bit too much. When we fly back, we probably do the same. As for melatonin, I'm a opponent to extension of life, to extend active life. I agree. I would like to stay alive for a while and to do something important for science, but it means being sound and in the proper state of mind. But just to live for the sake of living and be dependent, creating a lot of troubles for your a relative. You need to be carried in a chair, but why? I will never forget, though, when in Soviet time, working at oncology center, Professor Reiklin took me for a tour of Blokhin academician when he went into urology department, which they allegedly saved from gallbladder, but they amputated his genitals, his limbs, and didn't on the plastic of his urine tract. And when the delegation passed, one American decided to stay and ask him, "How are you doing?" And he said, I don't need this kind of living, actually. So there should be a decent quality of life. And the active longevity is fine, but being immortal is unnecessary. Yeah, well, we need an active life for sure. And thanks for that story with the urinary bladder deletion removal. And good afternoon, dear Igor, dear Tatiana. I thank you for this lecture today. I'm a PhD student. I'm a radiologist, and I study effectiveness of Kali-Fabi PET CT in oncology. And one of your answers, you mentioned FAP. FAP. I don't know what it is. Maybe I didn't hear it correctly. Fibroblast-associated proteins. And what is that? No. But go ahead and ask your questions. Maybe I will try to answer. Fibroblast-associated proteins is what interests me. They play a key role. It's also part of molecular diagnostics. These proteins are on the surface of the tumor-associated fibroblasts, and they are responsible for mutation of cells, for the migration, for the adhesion to normal cells, and they turn normal fibroblasts into cancer fibroblasts. Go ahead. I already know what to answer. I would like to hear your opinion about the prospects of this protein as a marker for diagnostics and as a target for theranostics. So my response is that I didn't mention this fact, but I now recollect that a number of years ago we studied transcript proteins that are generated by fibroblasts of the microsurroundings of the cell, right? And how they influence the tumor progression and metastasis. We studied it at prostate, but we shouldn't say fibroblasts turn into cancer cell. Cancer cell is the cell of epithelium. This is just between us. Fibroblast is a connecting tissue. So indeed, fibroblasts can be seen in cancer cells, but they create micro surroundings. That's trauma where the cancer cell is, and it's transcription proteins that turn committed fibroblasts into communicating. If their synthesis is suppressed, the feeding of the main tissue is stopped because fibroblasts will not develop, and then microvessels will not develop, and so forth and so on. And the forecast of these epithelium cells of micro surroundings consisting of fibroblasts is more favorable. So studying fibroblast producing proteins is one of the most relevant prospects of biomedicine development and the ways of impact on malignant tumor. Any other questions? Well, dear Igor, good afternoon. Question for you. You have an idea why melatonin of Leningrad children was higher than norm? Do you have your hypothesis why melatonin of children of Leningrad was higher? Well, we can make up a lot of stories, and I will start backwards. I know that time is flying. There was a famous academician, Likhachov Dmitry. He commented first the word about equal regiment. So he was arrested as a student based on the report and spent 7 years in the Solovetsky camp. But he lived over 90 years, and he was sober-minded. All the journalists asked him, what did you learn? And he said, I pick up one skill, that I was always hungry there and cold. So reducing your calories and making your environment adverse. Olga was right. It's not right to put yourself through such a test. And those who went through repression through Stalin camps, they live longer indeed, and they're less prone to oncology disease. Maybe it's a payoff, a compensation by Lord for them. Why is it associated with melatonin? It's the hormone that regulates your biorhythm, circadian. There's no light. There was no light. It's Leningrad. It's always bad lighting, poor light. People were living, lack of light, and there was more melatonin. And the gastric tract generates more melatonin, and maybe this continuous hyperexpression of one hormone will force to work one gene that on the basis of a feedback will be generated for the rest of the life. I'm just making this up. Maybe that's possible as well. Concentration of melatonin in selenum of those who survived blockade, it's statistically proven, and that's been published abroad, that they found more melatonin in saliva. We've been talking about hunger for the second time. Can you comment my suggestion? There was a test done in monkeys, and it proved that the dominant species have increased serotonin, and subjugated has reduced melatonin. And this could be explained by the ability of certain species to control their fear and aggression. So my hypothesis is that children of Leningrad, for their survival, forced to control their fear and aggression. Based on that, their serotonin went up, and the melatonin is synthesized out of it. If we go to rise, they were able to control their fear and aggression. How can you control your fear and aggression? When you're scared, how are you able to control it? Or when you are aggressive? Fear is unconscious conditions, not a single person. Dmitry Semyonov, he, as a surgeon, as a decisive person, he would, I'm sure, be happy to cope with this one. I apologize for violation of the protocol. My father is not alive anymore. He used to live through the blockade, and from the first till the last day, and he was around 1 year old. He survived. He was the only child from his residential block, and he survived thanks to a number of reasons. Maybe thanks to his genetic heritage and legacy, and but my grandmother, his mother, from day one, she would give away all the food to my father, and maybe all these factors contributed to success of my father. I think it's erroneous to talk about aggression and fear. These comments are not valid here. But the genetic tendencies and predisposition is what matters. Those people who have survived in the Stalin camps, these children who have survive this terrible situation, this siege and blockade of Leningrad. It's probably what helped to retain the strongest genome fund. And we see how it later resulted in life longevity and what Igor has told us in his lecture. So I don't think it's an issue of aggression or regulated fear in that particular case. Thank you very much indeed, dear Dmitry, and it's a very detailed response with a good rationale. We hear that the masterclass is about to start, and we don't want to keep people here. I want to thank our extraordinary scientists, remarkable scientists, dear Igor, for his invaluable contribution to global and domestic science, national science. He's a true scientist, a pioneer, and he is busy with this difficult subject as signal molecules, markers, targets, and everything what relates it. Let me steal another minute of your time, because in your presence I would like to present a gift for Valeria. One gift goes personally to his name. I'm having fun in my nighttime, and when I sleep, I'm also writing some books. There's a scientific. Hold on. I'm just desperate to. That's why I take it from it. It's a book for your family. It's not an advertisement. It's traveling around the world of medicine. When they ask me what was the article that I wrote with the highest pleasure, I tell that this book is my top pride, because this is where this is what I've been doing for the past 40 years. It's my gift for you, dear Valerie. And the second book is about this very signal molecules. It puts you asleep quite quickly. And this is to mark 100 years of our university. It's about the methods, the equipment that we have in our department, how we do translatory biomedicine. And my second package of gift to you as the director of the Center of Preventive Medicine, Innovative Preventive. So this is a plate of our small city Pavlovsk, be it present in your office. It's made of Tsar porcelain. Molecular symphony, or this magic symphony of life, is going to be having a stronger sleeping effect than dear Igor. And, we thank you both. Please take your seats. A round of storming applause. Thank you very much indeed. And we are happy to begin a series of reports by our scientists from Kazakhstan. And on behalf of the moderator, I would like to remind you about the time limit, so please make sure you respect it and you stay within the time boundaries. We move on to the next report of our Nobel Festival. It's going to be delivered by Viktor Balbachan, founder and director of the International Companies Medical System SOS and SOS, Institute of Human Safety, and Nurtegan Mohamedaliyev, co-founder of International Companies Medical System SOS and Institute of Human Safety. They're going to take us through the patient safety in the modern technological world. Hope you can hear me well. How about that? Hi everyone. This is how we say hi to each other in WhatsApp because we are a Kazakh company, but at the same time we are an international one. We have some associated companies in Germany, in Taiwan, and in China. My name is Victor Balbachan, and I'm delighted to tell you about what we're doing. I represent here medical and technological international company that is called Institute of Human Safety. The speaker before us, our lovely Igor Moisevich, has taught us a lot about quality of life. We dedicated all our business work to human safety, the safety of a patient. Patient safety is an essential element, and I feel that it's often neglected, undeservedly neglected. Let's look at our healthcare system from the standpoint of patient safety. Lack of funding for a medical institution is a risk for safety of a patient.
Shortage of personnel, shortage of medical personnel can serve as another factor that affects the human safety. This also includes some obsolete structures, buildings, different factors that affect the safety of a patient. Who is a patient? A patient is your friend, relative, and we are at one point patients. And I think that me and my team need to look at the healthcare system through the prism of patients' safety. I would like to tell you about how we ensure patient safety and how we improve patient safety. Our work is closely linked with the work of experts. Experts of different levels in the healthcare system. For example, in Germany, we cooperate with the association that includes 4,000 doctors. In Kazakhstan, we cooperate with the Association of Experts and Consultants. They consist of 290 people. We identify problems. We, let's say, look at the problem in order to find out what was the prehistory, what actually happened. For example, when a patient is received in the intensive care ward, he usually sits on the bench waiting for his turn. There are some emergency patients, but there is a gold standard of 15 minutes when a patient is supposed to be provided with urgent medical care. Even if a person stays alive, but if he does not receive help within the first 15 minutes, his health may be damaged a lot. Maybe then a person will suffer from a very high blood pressure for the rest of his life. But why such situations tend to happen? That's because of the shortage of medical personnel. For example, in the intensive care ward or in the inpatient hospital, these surgeons may be present both here and there. I mean that a surgeon can be called to the intensive care ward, or a surgeon may be having a surgery or an operation, and in that case, the patient will not develop the SOS system. That resolves such problems. What do we do usually? We talk to experts.
Тайвань, у каждого своя зона ответственности. То есть, если это, допустим, представители Китая, то мы знаем, что там уже очень много разработок уже есть. Мы подбираем необходимые модели и собираем для этого решения разные софтвер, хардвер, какие-то софтверы, хардверы разрабатываем сами, делаем такой продукт. После этого этот продукт мы уже интегрируем в систему здравоохранения. Дальше мы этот продукт ведем, сопровождаем и его улучшаем. Таким образом, у нас сейчас работает порядка 260 медицинских организаций. Если брать развитые страны, то, допустим, в Германии у нас 10 медорганизаций работает и там порядка 100 врачей, да, уже работают. Вот теперь я хотел бы пригласить своего коллегу, который наглядно покажет, какие продукты, какие решения есть. Его зовут Мухаммедалиев Нуртуган. Он сооснователь компании. Давайте поприветствуем его вместе. Он сейчас более подробно покажет, расскажет и...
Спасибо.
Окей.
Спасибо, Виктор Викторович. Саламатсыздар ма, құрметті форум қонақтары. Здравствуйте, дорогие гости форума. Мы, учитывая, что чуть по времени немного сдвинулись, будем сжимать наше выступление. Сегодня хотелось бы переговорить с вами и затронуть тему, как повысить безопасность пациента через призму цифровизации. То есть мы представляем Институт безопасности человека, как ранее сказали, на протяжении долгих лет мы занимаемся именно вопросом повышения безопасности пациентов через IT-решения. Что такое в целом безопасность пациента? Всемирная...
So the World Health Organization gives its own definition to this concept, saying that this is the high level of psychological condition of a patient who is on the territory of the medical organization for his treatment. And in 2022 in Montreal, the document was adopted, and it's called the right of a human being to safety. Unfortunately, the safety of patients is considered one of the most serious problems of healthcare globally. It's not the problem observed only in Kazakhstan. And it is said that about 50 incidents or events related to extreme events could be prevented or avoided. Taking into account such trends, we decided to deal with this issue so that we would reduce the human factor in the organization of help or in the provision of medical help. So what are the objectives? First of all, we need to know about all existing risks. In order to have this opportunity, we need to properly analyze information and prevent potential risks in the future so that it would not turn into a trend. And this is possible only when there is a manageable risk. Risks shall be controlled or shall be manageable. And this is what our institute deals with mostly. For that, we decided to divide our objectives into several stages, such as the collection of data or the spread of data about mistakes, analysis of the sources of these mistakes, root causes and methods for prevention of such mistakes, awareness raising by the healthcare specialists and suppliers of medical services, support of the legislative changes and regulatory changes. Over the years of our work, since 2013 and 2014, we've created lots of projects in the field of healthcare, and in a nutshell, we can list here the SOS medical system, which was mentioned earlier by Arkady Viktorovich, who said about the hardware and software that coordinate the actions of the medical personnel in case of emergencies. For example, we looked at one of the case in the intensive care ward, and this system works well in order to reduce the human factor. And increase the resources in order to establish the communication bridge between a patient and the medical personnel, especially when a patient needs an urgent care. Technologies of handling the high-risk medication, this is one of the priority issues because the human factor or the human nature is inclined to making mistakes, and there are lots of incidents observed not so long ago. Now, for example, these were the incidents with regards to the patient's identification. A person tends to make mistakes. This is the human nature, and that is why the digitization can help a lot. So we have to regulate these processes. Together with the international objectives for the safety of patients. And one of the projects is the system of smart identification, which we developed back in 2014. And it is our Kazakhstani product that is available on iOS and Play Market. This is the bracelets, and we've added some technical solutions to these bracelets because our bracelets can be used for multiple times, and they have the encrypted QR code. Since the patient's number goes down globally in terms of the prevention, we created the bracelets that detect the fall of patients because they tend to fall a lot in hospitals. This is the bracelets aimed at preventing such falls or at least detecting such falls. So as for the distant monitoring of patients that have non-communicable diseases, and there are 3 nosologies in Kazakhstan, here the same application, the same information communication application was developed as part of the protection of motherhood and childhood. That means that the pregnant women, without any direct contact, can remotely get an appointment with their doctors or get in touch with our call center. Last but not least, this is the development from 2023. This is when we launched the pilot project in Aktobe Medical Center, and this project is the continuation of the SOS system, which is aimed at integrating the services with the intense care wards. This is the SOS emergency connection that allows the monitoring of the transportation processes as well as improvement of interaction between personnel in order to provide timely care. For example, one of the stroke centers in Almaty accepts patients under this system. They have the special classifier that a member of personnel is supposed to fill out at the patient's bed. It is really inconvenient to write these things down on paper. Therefore, the personnel members usually do this on paper, even if it's not really convenient. And therefore, we suggested using a more convenient interface so that they could use the digital options in order to fill these forms out. And we now considered all of the nuances, and there are respective brigades and respective manipulations available now. In total, this reduces the time for the provision of care, and it allows us to ensure proper coverage of patients in need. We already talked about the risk reduction, and in order to reduce risks, we need to know how to control risks. For that, why do we have risks? Well, it is obvious that there are different situations, and in general, the hospitals themselves are not the closed type institutions, and they are not in the vacuum. They are affected by different factors, including the human factors or some other incidents which cannot be foreseen in advance. So, can a medical institution cope with these risks? It depends on a medical organization only, and therefore we need to integrate the safety culture. A lot of developed countries started to develop so-called CIRS systems. These are the critical incident report systems. And we can look at the example of lots of international companies. This is how we created our own system in order to minimize the human involvement in the response to incidents or events. First of all, what is really important to note here? The methodology itself is important. Any mistake that happens must be anonymous. I mean that if someone inserts information into the database, he or she needs to be sure that the data are anonymous. Quality experts that usually analyze these events shall guarantee the lack of punitive environment. In Aktobe Medical Center, in the last 5 months, we've achieved lots of positive results, particularly by applying the digitization approach. We use the QR code, and in our next slide, we'll provide more detailed information on how everything looks like. So this is the QR code that gets a person here. This is the bot, a Telegram bot, where an expert can consider the entire event configuration, and then it gets access to this analytical information. This is the first stage of the creation of the Kazakhstani CIRS system, which is anonymous. It's the anonymous network for reports and critical events. And this is functioning well globally, and therefore we would like to create such reliable systems in Kazakhstan. All of these reports are covered by the database, and in order to store these reports and to process these reports, we need to be guaranteed the proper cyber security levels, and therefore we have experts in information security. On the basis of these analyses, the institutions develop joint strategies to eliminate common sources of mistake in order to properly ensure the culture of safety, which means that different incidents get recorded in an anonymous way, and experts can freely open in an online mode the entire morphology of an event and give their own evaluation, analyze root causes, and respond to a certain incident. A person who fills this form out and the person who sees the response, in our opinion, will be fully aware, and this will prevent future incidents, ensure the higher culture of safety. I also would like to quickly show by the way, this is where we show the international best practices. When we just started our pilot project last year, we've looked at the experience of different organizations that integrate such systems. We looked at Germany, at our German partner, and we are now holding negotiations with them on the transfer of technologies. That's what Igor Viktorovich was talking about. There are also Canadian technologies. There are Swiss technologies, which also focus on pharma and on clinical events. As for pharmacology, the Canadian experience seems to be very interesting, as it gives the opportunity for every patient or for every citizen who bought a medication to share his or her comments about his medication. And in case of side effects, he or she is able to provide more detailed information. There are certain trends observed, and I believe that the Committee for Pharmaceuticals Activities is now, after such events take place, have to come back to the medication and study them all over again. In Kazakhstan, we are ready and are open for a dialogue with our partners, with clinics, with the scientific centers, and we invite our researchers to take part in our pilot projects. We are based on the Expo site in Astana hub. It's the first international IT park in Kazakhstan. We've been working for a while. So, to wrap up, as Viktorovich said, we started with the smaller steps, and now we've learned from our previous lessons. We see what methodologies got obsolete. The checklist of the intense care ward was on paper, and we thought about putting it into the electronic format. We did it successfully. We took our measurements. We saw the effects, and the ambulance didn't want to go digital because they were quite used to using the traditional methods of work. But usually doctors are busy with writing or filling out different papers, and we can only save patients by using such small innovations and solutions. If we combine all of this together, it'd be possible to come up with a comprehensive solution to ensure the patient's safety. And we cooperate with the organizations from Germany. Since last year, we started to work with China and with the capital of chips, Taiwan. And our partners see the potential. That is why they work with us. They see that we implement social projects, and today here we have lots of our partners and friends of ours. So we invite everyone to cooperate with us. Thank you very much. I just wanted to emphasize that in our country, we have national standards of healthcare, and this is a great source of happiness for us because not every country is capable to do so, and lots of countries have been working on this for a long time as well. There are such countries as Russia, which, on the contrary, learn from our experience, and that is why I'm very glad to see that our national standards have a provision about the security and safety of patients, and we're going to develop this provision all together for the sake of our country. Thank you very much. Gentlemen, thank you very much. Viktor Nurtugan, thank you very much. Dear friends, we're moving on with our speakers who are going to share their experience of the system of international accreditation in healthcare, experience of Kazakhstan. This topic is highly relevant because this is one of the key components of the standards of medical care and safety of patients on the international level. Our speaker will tell us about how Kazakhstan integrates global practices into its healthcare system, which is an important step in ensuring high-quality medical services. Let me give the floor to Botagoska Upaeva.
Добрый вечер, уважаемые коллеги. Я смотрю, наверное, многие ушли на...
I see that a lot have left for the close master class. I would like to share the experience of our international accreditation that we've been holding here in Kazakhstan for over 15 years. It has symbolical meaning to see that the Nobel Fest is taking place on in the same year as we celebrate our 15 years. So I'm sure that there will be new goals set up for Kazakhstan in terms of national accreditation. And we would like our experience to be translated and integrated into international standards of our post-Soviet countries. I would like to note that over 15 years, thanks to our government and the Ministry of Healthcare, Kazakhstan is among those participants who have joined and that was accredited according to the International Accreditation Program. The International Society on Quality of Education is an umbrella entity that is accrediting body for all accrediting institutions. And you see that around 40 countries, including Kazakhstan, have been actively developing this program on these international goals of patient safety, the international standards that our partner is recommending, International Society for Quality of Healthcare. Through these standards, translating quality across the world. We have received accreditation in 3 fields. We have 2 sets of standards accredited. It's for the outpatient and inpatient aid. So we are training healthcare specialists on national standard accreditation, and our entity was also accredited on quality of education and quality of healthcare. We've been doing that for 7 years, reassuring that all the processes that we have embedded, national, international principles, they are implemented in Kazakhstan, and we can also translate this experience at international level. Just a little bit of our history, dating back 15 years ago, in 2005, under the auspices of Ministry of Healthcare, the first set of accreditation were done. Many institutions know very little about what is it like, how it should be done, and nobody knew how this kind of assessment should be done. So this was a joint effort on the side of medical institutions and healthcare specialists on accreditation, approval, and adoption of standards, development and approval of standards, and this gradual work, gradual implementation started, and starting from 2019 as a self-regulating institution, as a public association, we've been working in Kazakhstan. We've been accrediting medical institutions. We are responsible for standard elaboration, and our know-how of some kind is that we are also doing post-accreditation monitoring. Not all accreditation entities are going for post-accreditation monitoring because this service is a costly one, but I feel like it's a great instrument for Kazakhstan to maintain quality of standards, to make sure that the quality is there. When we speak about the national field, we are accredited by the National Healthcare Ministry. We have authors' know-hows and inventions and all know-hows in terms of standards that's been introduced. This is our author's product. And you see that we have accredited 472 medical institutions so far. That's around 42%. And that are working with the mandatory medical insurance fund. And according to statistics, you see we have some leaders and, well, anti-leaders, anti-heroes whom we are actively working with, and I'm sure that this should be an all-round effort. When we speak about different categories of accreditation that we have introduced since 2015, they can receive first, second, or third category. So, giving you example of Western regions, I can tell you that is the second and first categories that prevail. Naturally, there are medical entities that are preparing themselves, introducing standards, adopters of this and proponents of the standards, and they post some good results. And we have introduced some motivation instruments to boost accreditation. As I told you, 42% in Kazakhstan undergo medical accreditation because it's a voluntary procedure and there is no financial incentive. However, the medical insurance fund offers some privileges to those who have received accreditation, and they get a priority when deciding on the purchase of services. And they exempt them from monitoring these inspections that they do at for others are not covering accredited institutions. Prevention control that is done by a supervisory body do not cover those institutions that enjoy the same status. And in the rating of local municipality, they also track this indicator. When we look into details as to how the standards are upheld, you can see that the standards that are regularly monitored, not only at the level of the accreditation center, but also at the healthcare center, local executive authorities are implemented more successfully, and there are some reasons for happiness. You see identification of a patient, hand hygiene, falling risk. They actively introduced at medical institutions because it's a requirement of not only accreditation but also there are checklists of the supervisory bodies that have bestowed it upon them. Naturally, there is a lower rate in terms of building safety, safety of medical drugs, and so on. And naturally, we try to support our medical institutions, our clients that turn to and seek our support. You see that the difference of accrediting body of Kazakhstan is post-accreditation monitoring. When are we going for that? When we have some doubts and we're hesitant about the comprehensive external assessment. So the group went out. There are certain assessment points and scores, but we have some doubts. Then we can do a repetitive visit. Or there is a case when the accreditation center happens to know about some case that put a patient at risk. When the patient safety is compromised, when we can go for comprehensive assessment, or when a medical institution is not diligently performing its corrective actions, then we can go for a focused or targeted evaluation. We work actively with our inpatient centers. They share their achievements in the social media. It's kind of norm of modern reality and the norm of life. And the categories that they finally win is their source of pride, and they actively sharing that, congratulating each other because it's an achievement for the entire team. It's a product of teamwork. As I told you, we work not only in the national jurisdiction, but we also going for other destinations. We are working as an international accrediting body for our international partners. The first clinic that we have accredited is an Israel clinic of Hadassah that is located in Moscow. They were truly interested to make sure that our standards are introduced at the medical institutions, and we expect that this clinic will again be repetitively accredited. Uzbekistan also seem to be interested in introducing the same principles that Kazakhstan did. So starting from year 2022, they've been preparing for the accreditation of a large clinic. It's obstetrician hospital. It's a gynecology and obstetrics hospital. And the Mongolia clinic has also received accreditation for the country with 3.5 million population. So undergoing an accreditation was also a huge honor for them. They were celebrating it at the national level, and just in November, very recently, we went to Ulaanbaatar to congratulate our client, our hospital, where all ministries were involved, embassies of the neighboring countries. So I think it's a huge pride, for Kazakhstan and for Mongolia to develop our friendly ties even further, not only in trade, but also in healthcare. Our partners are such institutions that are present in Kazakhstan, but we work actively with the Institute of Quality of the Russian Federation, Azerbaijan, China. We work with such accrediting bodies with our peers and counterparts abroad, and we work closely with the Institute of Quality in the United States, where our consultant, Professor Asaf, is also
operating and cooperating closely with us. Like I told you, our standards were accredited, and we have a full pack of standards that were drawn in line with international requirements, and they've been actively promoted. It's the blood service standards, emergency medicine, palliative care, sanitary aviation, and we are introducing standards on rehabilitation amid post-COVID period. The chapters of our standards, they cover the entire spectrum. It's financial economic parts, governance, resource management, safety management, treatment and patient care. Last year, the updated standards, they also include requirements for the safety, and they're highly relevant, so you can track our standards on our website. You see plenty of data and information available on our websites and social media. Please feel free to share it with each other, because we're open for your collaboration and information exchange. We actively engage on speakers and international speakers. A little update about our plans for the future. Like I told you, we are promoting our international partner relations. So as of today, we are in close collaboration with Turkey. Turkey is also interested in developing tourism over there. We are opening our office in Tashkent because, like I told you, we have seen deep interest of Uzbekistan in transfer of technology on accreditation, and 15 medical organizations are going to proceed through Uzbekistan because grant funding goes through Tajikistan, Afghanistan, Mongolia, Armenia, and so on. So it's going to be under the guarantees of Uzbekistan. We are accommodating international delegations from Mongolia, Tajikistan, and we host a lot of study tours, and we show them best practice not only in the national center but our city medical entities. Recently, we started collaborating with a Spanish company and has been actively cooperating on building safety medical institutions, and I would like to highlight in particular, since the time is pressing, the 15 years anniversary of our center will be celebrated as part of the conference that we're going to hold on 15th and 17th of September in Astana. It's going to be under the auspices of WHO, an international society for quality of healthcare. I invite everyone to attend this event. There is plenty to share if you see yourself as a potential speaker, so we will be happy to see you as well. So over here we have the QR codes for our social media. There are our contact details. Dinara is also next to me, our PR manager, who can equip you with more information about our social media. That's it from my side, and thank you for your attention. Thank you very much, and we are not stopping here. We would like to invite the next speaker, Head of Med Support, Dia Batagoska-Okeanova, evidence-based medicine from blood leading to randomized clinical trials, Doctor of Medicine, Newsom resident, Head of medsupport.kz. Is it on? Yes, I hope you can hear me good enough. So, hi everyone. Thanks for being here. I know it's been a long time, a long day. It's nearly end of the day, so I'll try to make it quick. Please don't read too much into the title of my presentation. Well, I wanted to call it fantastic creatures, or how we will cure you from money. And I was told that it's not going to fit for this format. However, I will try to pay more attention to charlatan in healthcare. It's a scientific term, so let's be cautious with that. So please bear with me. I apologize for my voice. I was sick last week. I'm not contagious anymore, but I hope my voice will withstand. So I can go without a slide. Who am I? I'm a doctor. I'm a third-generation doctor. I have a bachelor degree in biology, and I'm also head of the volunteer project Med Support KZ. I can talk a lot about medicine, even if you don't ask me. So if I go beyond the time limit, just wave at me or throw something at me. And now about medicine and charlatanry. Which of you are health workers or medics? So now more about there are different types of tricks that don't really help. It's a long list of charlatanry, and what is of that is being health. It's all product of charlatanry. Fraud. All of that are actually medical practices. It was all captured in history what doctors thought, like mercury from teething, heroin for the treatment of morphine addiction, bloodletting as a treatment for colds, enema for depression, hot iron from love sickness, St. Hilary's key to rabies, and lobotomy for hysteria. So healthcare, medicine is a weird science. If you remember history of healthcare, when there was no anesthesia, they would just hold you tight and cut your limbs. When there were no blood suckers or leeches, they would do something else, just maybe cut, make incision, and so on. So I would like to give you an example about charlatanry that it's not equal that someone wants to deceive a patient. So in the past, people do believe in what they do. In homeopathy, let's take for example, they raise those of you hands who believe in homeopathy. Well, I'd be really skeptical about it. Homeopathy was established in 1976 when the physicist offered an alternative method of treatment for a patient. However, we remember how the patients were treated in 18th century. He proposed an alternative way of treating patients. He was shocked by ineffective and harmful treatment of modern medicine. Try to recollect healthcare in 18th century. They would do enema because constipation was the main problem. They thought they would make blisters on their skin from different diseases because this should somehow help. When they're sick with measles, they somehow treat it this way.
And in addition to this, let's keep in mind amputations from my favorite surgery. On this picture, you see how gods look at the state of medicine, and you can see Samuel along with them. By the way, he was in a med school, but then he left the med school because you can imagine the medical student who wants to help people, and he understands that blood suckers of bloodletting means something not like a nonsense, and that is why he came up with his own method. His method is about the drug. The more diluted the drug is, the more potent it may be. We can get one drip of this diluted drug and keep diluting it even more until we end up with the liquid that has zero molecule of the source substance in it, and it was considered something really strong. So everything is based on the water memory, the water that has a memory. So one can imagine the situation: a person got a cold, and you think that you can treat this cold by bloodletting. A lot of famous people died of this. George Washington, the first U.S. president, caught a cold, and the doctors decided to use bloodletting in order to balance the liquid ratio in his body, and he eventually died because the doctors back then overestimated the amount of blood in his body. But imagine we use bloodletting to treat a person, and there is another person against whom we use the homeopathy, which means that we're doing nothing. Who will survive with a greater likelihood? Probably it will be someone who preferred to use homeopathy against his cold rather than bloodletting. So that was the thinking of the past. But it was in 1796. In the 21st century, does it make any sense to stick to this theory? Is it reasonable at all? Because medicine is developing, science is developing. We even have medical robots. We know about a lot of mechanisms that we can use to treat patients, but homeopathy still adheres to older principles which were applicable in 1796. And whenever we talk about the evidence-based medicine and our relationships with the patients, we have to tell them, we have to teach them to see that the science and medicine are changing, and if there are some older principles that are still being applied, then it is more likely that it no longer works. Here we are gradually approaching the evidence-based medicine. This person is Archibald Cochrane. He was one of the founding fathers of the evidence-based medicine, and since we're short of time, I'm not going to dig into details. Nevertheless, you can take a picture of these slides. So what did he do? He was a researcher and a doctor, and he ended up in the Nazi prisoner of war camp in 1941, where he conducted the first randomized clinical trial. He was treating patients from Beriberi, and the history of this is very interesting. So you shall read his article that is called the sickness in Salonika, my first, worst, and most successful clinical trial. But he is more famous because of his second work that is called Effectiveness and Efficiency, which means that he tried to assess the effectiveness of the healthcare system of the Great Britain. Back then, NHS used to be a large structure that received lots of investments, but no one really understood how this structure worked. No one really realized that a lot of money was spent on something meaningless. So he was one of the first people to analyze this, to analyze what worked and what didn't work. And it led to this work of his. And Cochrane, the independent library of Cochrane was named after Cochrane. And if you didn't know, he carried out large meta-analysis on different topics. And Cochrane is the founder of the evidence-based medicine. He created this evidence-based pyramid, and I think that you've heard of this pyramid or you know about this pyramid. What do we do here? We see weak evidences on the bottom and good evidences on the top. On the bottom, we see expert opinions, experiments with cells, with rats and mice, but then come meta-analysis and systemic reviews on the top. So I just wanted to say here one more thing. We are speaking here about the evidence-based medicine, and expert opinions here cannot be ignored. Just remember COVID-19, it was a brand new disease and no one knew what to do, and we purely relied on the expert opinions then. But 4 years passed by ever since, and now we have research results. And if I go and ask for an expert opinion about pulmonology or virology of COVID, it would be wrong because it would mean a bad science. That is why if you're still studying or if you are conducting a research, this is the very base that you must be aware of. So, it may sound clear and understandable or straightforward, but based on what I see nowadays, it is really difficult to find the subtle line between science and pseudoscience. So if you spend a lot of time on Instagram or TikTok, just like I do, or if you spend lots of time online, then you will probably see lots of biohackers, researchers, integrative doctors who use very clever words. They sound very convincing. They use lots of scientific terms. I personally listen to them and I wish I could believe them, but since I have a medical background and I'm in medicine, I understand what is right and what is wrong. So we need to realize where is that subtle line. It is quite difficult, and probably this is one of the reasons why we need to integrate critical thinking classes into school programs and university programs. These are the major bullet points that you can take a note of or take a picture of. I don't know if I shall focus on them in details or not, but in general, when we speak of medical or scientific theories, well, have you ever heard of falsifiability principle? And no one is nodding yes. Well, anyway, if you are interested in research, read about the concept of falsifiability, because this is one of the principles of the scientific theories. For example, the statement that in my garage there is an invisible fast-moving unicorn that can be seen or smelt. Is it a falsifiable statement or not? Well, in theory, I cannot really hold any experiment which would prove that this is not true. It is really important for the scientists to conduct such experiments that allow for me to do my best to prove that my hypothesis is wrong or is false. Only then we can develop science even more. Of course, I'm not going to go into details, but let me give the example. God exists. This is something that we cannot really falsify. For example, I cannot come up with an experiment which would prove that God does not exist. Therefore, in the scientific, we cannot call it a scientific theory, but in theology, it may be considered as something different. Another thing that I want to draw your attention to, when we talk about the pseudoscience or science in general, it is not enough to believe in bioplausibility. For example, biohackers, they mostly rely on some theories that may be possible in a human body or in human cells, which means that, let's say, one type of grain can save me from cancer. It does not really work, because if something works in theory, it does not necessarily mean that it works in practice with human beings. Or, for example, if we look at, let's think, if we look at the program of antimicrobial resistance, we realize that in 50 years we'll have zero antibiotics if we do nothing. Well, I decided in Petri dish, I have cancer cells. And I have a mechanism that proves that gasoline. Oh, sorry, not cancer cells. I'm sorry, we're talking about antibiotics. Let's talk about staphylococcus cells. So we know that gasoline kills such bacteria. I take gasoline, I pour gasoline into my petri dish, bacteria are dead, which means that in theory I can prove that this mechanism works, which means that I will use this mechanism to treat people. Of course, no one's going to do that because no one will drink gasoline in order to treat oneself from staphylococcus. This is just one of the examples. We trust data, not mechanisms. It is important to see that correlation is not the causation, and this is something to remember if you want to hold research. And my favorite phrase, I'll fund public med for any nonsense, pub nonsense for any nonsense. Well, in PubMed, there are more than 128 million articles, and no matter what nonsense I want to come up with, I will be able to find something in PubMed, and I tried to do so. This slide, you should take a picture of this slide if you are interested, because when I wanted to talk about the cognitive distortions, I know that this is a very interesting topic and a very interesting and a very important topic for the evidence-based medicine, but this is something that shall be reflected in a separate university class. So please take a picture of it and please shoot me a message if you want to talk about it in detail. So we'll skip this slide. I created this slide for you if you're interested in learning about the sources, and if you are interested in evaluating sources. I think that I gave a lecture to mass media representatives saying that how we can actually evaluate different scientific sources. And this is a brief guide which you can actually use. If you're interested in taking a picture of this slide, please go ahead. We're not going to focus on this slide even more. I wanted to focus more on practical examples. So let's speak of the authorities. In medicine, if you are in medicine, then you know very well that a lot of things depend on the expert opinions and authorities. And we need to understand, though, that even though there is a very clever person, no matter who he or she is, whether he is your supervisor or the Nobel Prize winner, it does not necessarily mean that whatever he says is true. If you go online and look at the clinics in Astana, there are lots of clinics based on some other methodologies, and this is something that causes concerns on my side, because medicine is something that engages the knowledge of the entire humankind. If you are inventing something on your own and no one else can do the same thing, then probably the problem is with you or with your supervisors or with whoever, because scientific knowledge must be reproducible and it must be able to be repeated for many times regardless of someone who invented it. And authorities do not matter. So here, this thing works really well. This is what we call an integrative medicine, and this is something that I wanted to focus on, even though I have a few minutes left. I see that there is a big number of people who focus on the integrative medicine, and I expect this number of people to grow. We will see more doctors, more clinics, but integrative medicine sounds really well. This is the medicine that combines traditional and alternative approaches to treatment. For example, we take the best of the two worlds, but if we think of it, integrative medicine includes lots of nonsense, such as homeopathy, Ayurveda, osteopathy, chiropractic. This is the Trojan horse that tries to come to us, to our country. This is the global phenomenon. The healthcare system all over the world deals with problems, and integrative medicine is like this Trojan horse which is being pushed to our countries in order to spread this charlatanry among our population. This is not my personal opinion. This is the opinion of my colleagues. This integrative medicine is more about rebranding of charlatanry. Initially, it used to be considered charlatanry. Then it was called the alternative medicine. Then it was called the complementary and alternative medicine. And we were even taught this in our medical university. We talked about the needle therapy and so on and so forth. But now it got rebranded into the integrative and functional medicine. And these are pretty much the same things. For example, at one point, people would sell potions. Now these potions are packaged differently, and now they are being sold in nice-looking clinics. And as a patient, I would probably want to be treated in the first hospital rather than the second hospital on the picture. And this is the reality. The second picture reflects the reality of the hospitals of different countries, not only of our country, but medicine isn't equal to wellness. Biohacking, functional medicine, integrative medicine are mostly about entertaining healthy, young, and rich people. When such patients come, it works, but when we see these patients turning into those patients and we see them in intense care wards, we realize that it's too late to do something. That is why please be mindful of such things, and please share this knowledge with your relatives. My time is up, so I'm not going to focus on this. The whole point of this slide is that it costs money. This is a very big industry of billions of dollars globally, and Kazakhstan, in this sense, falls 5 years behind, I think, or even more. But we expect this to emerge here. It will generate lots of cash flow, and therefore people will pay attention to it even more. And in conclusion, I would like to quote a very famous phrase. Do you know how the alternative medicine would work? It would, if it worked, it would call just medicine, not alternative medicine, because medicine is this greedy bitch that takes everything. Even if we have a slight hope that it works, medicine will take it. And I don't want to say that I am so radical. I believe in lots of superstitions. For example, by looking at this picture, I see that I'm wearing a hat that my father used to wear because my father is a surgeon. And I want to think that, yes, it works, it helps a lot, this is a superstition. And doctors have lots of superstitions that they try to follow. And it seems okay to believe in such superstitions. It is humane, but it is abnormal to treat people by using these superstitions only. I hate the concept of evidence-based medicine, though, and because I think that it is strange, as any working medicine is the scientific medicine or just medicine, and therefore we need to get rid of these terms and say that whatever works is medicine. Thank you very much. This is our information on social media. This is my personal account on Instagram. If you have any questions, please go ahead with your questions or write your questions. Thank you very much. Let's give a round of applause. We just wanted to remind to our speakers that we are limited in time. There are 4 speakers left. That is why I suggest that we let us be respectful to each other, and let's stick with the time limit. Our next speaker is going to talk about the features of the course and tactics of treatment of gout in elderly patients. Let's proceed with our exciting agenda. The floor goes to Venera Khabizhanova, professor of the Department of General Medical Practice from Kazakh National Medical University, named after Asfendiyarov. Let's welcome her on stage. Hello, dear colleagues. My report is the report representing the scientific medicine. The relevance of this topic is determined by the prevalence of gout in different countries of the world. And this prevalence keeps growing. It starts from 0.9% and reaches 4%. The prevalence of gout in Kazakhstan is about 9%. It should be noted here that the hyperlipidemia that is the basis of the development of gout among people went up in the last decade, and it reaches 35% among adults.
So gout is deemed to be the most prevailing disease among elderly people at the age of 80. It accounts for 8%. As compared to a group of patients from over 50, gout can be seen up to, you see, up to 5%. You know that gout in women occurs during postmenopause, 1% at age 50 and 5% at age 70. Gout in most common disease among the elderly and seniors, 8 compared to 1.8 of patients. At age 1% at age 50 among women and 5% at age 70, the comorbidity of disease becomes a key issue, as gout is associated with a wide spectrum of cardiovascular diseases and renal and kidney diseases. We can identify several periods in gout course. It's asymptomatic hyperuricemia. It could be acute gouty arthritis. As for asymptomatic, it could be up to 30 years, and then there is a manifestation when the crystal of urine crystals. We see an acute gouty arthritis developed. By intensity, it's its maximum, and in the literature we can read it's like getting your feet in a trap. As for the symptoms, there are two first fingers that could be defeated. And then the relapse are getting bigger and frequent, and they turn into endless relapse. And in 5-6 years, we see a typhus develop on the skin, and it becomes chronic. Now about hyperuricemia, according to the definition of European Anti-Rheumatic League, it's a condition under when uric acids exceeds 360 micromole per liter, or 6 milligram per deciliter. It's when the crystal of uric acid stop dissolving in liquid media of organism. According to the literature, we all know that hyperuricemia, it's one of the components of metabolic syndrome. It's also a risk factor for development of further progression, and it relates to diseases of cardiovascular system and kidney system. And it's deemed that the level of uric acid that exceeds 360 micromole per liter, that it's already significant under serious cardiovascular risk. You see there are units of measurement. It's 5 milligram per decimeter. 1 milligram equals to 60 micromole per liter. So 9 milligram multiplied by 60, it's 550 micromole per liter. In this slide, you see the linkage of uric acids with the risk of cardiovascular pathology. There are different risk factors, and people of senior age have additionally drug therapy, because they have high morbidity, they consume a lot of drugs, and it's all contributing to development of so-called drug gout. Drug-induced gout. You see on the slide that hyperuricemia associated with a wide range of drugs. It's arterial hypertension. It's cerebrovascular diseases, renal and liver dysfunction. And if the patient has this issue of hyperuricemia, it's a predecessor of overall mortality increase. Here is the meta. You can add also here sugar, diabetes, and so on. You see that the increase in the level of uric acid leads to lethal risk from any. We see a 24% increase in the risk of death from any cause, increase in cardiovascular death by 37%. Here is the meta-analysis of the impact of hyperuricemia on kidney function. And here is the conclusion of this analysis, saying that hyperuricemia is associated with the speed of infiltration, increase and progression of chronic kidney disease. If we try to lower it down, maybe once a year and more frequent, it may improve the renal function. In case of gout, like I said, it has high comorbidity effect, and almost every patient with gout has 5 associated diseases. When gout is diagnosed, then the next disease is arterial hypertension, or chronic renal disease, or sugar diabetes, and many others, and coronary heart disease. If there is a patient with a gout in front of you, then you need to more actively find risk factors and associated diseases. You need to assess cardiovascular risks, first of all. According to the study that we've performed ourselves, we researched 280 patients with gout. Arterial hypertension and associated disease is seen in 91% of cases. Coronary heart disease, sugar, mellitus, 15.6%. Metabolic syndrome, 57%, and renal dysfunction, around 13%. We also mentioned drug-induced gout. Here are some drugs that can increase uric acids. These are different drugs that you can see on this slide, what heart doctors are prescribing for arterial hypertension, coronary heart disease, a low-dose acetylsalicylic acid. What lower it are different statins and fibrates, blockade angiotensin 2 receptor blockers, clopidogrel. It has no effect upon the urine exchange. According to clinical recommendations of the Russian rheumatologists, the main components of treatment are prescriptions of diet, first of all. It's this diet is not enough to normalize the level of uric acids. If there are attacks of gout, we prescribe colchicine, non-steroid, glucocorticoids as intra joints and parenteral and monoclonal antibodies to IL-1 to lower uric acids. In Kazakhstan, there are two drugs. It's allopurinol and febuxostat. Here in front of you are recommendations of the European Anti-Rheumatic League as of 2016. Well, they resonate pretty well with the Russian recommendations, as you can tell. What are the innovations for gout treatment to remove the attack when they cannot be removed by colchicine? When glucocorticoids are not effective, we prescribe gene-engineered therapy, and we have such a blockade, canakinumab, that is done subcutaneously, and adatinib that is used to remove the gout attack that is associated with fourth or fifth stage of renal dysfunction. So early treatment. Once the patient starts feeling some discomfort in the joint, you should immediately prescribe some drugs that help you relieve the symptoms. On the next day, you see it outspoken and pronounced. Red joint, stark pain, and we continue the treatment. Even though the symptoms have gone away, arthritis was curbed, we still need to continue to get rid of this exacerbation. Duration of treatment, discontinuation of treatment, exacerbation 2 to 3 days after has resolved. We'll continue treating gout, taking into account multiple comorbidities. Prevention of exacerbation, low dose PV therapy in first months of treatment. So what are some opportunities to remove acute phase of gout if a patient has chronic kidney disease? When the speed of infiltration is lower than 60, we can appoint colchicine, and PVP has contradictions, so we can appoint, if they have some ulcer disease, then all these drugs wouldn't work, and we can remove it with inhibitor of atelecin-1. If the patient has chronic heart disease and he is using anticoagulants, we cannot appoint NVP and glucocorticoids. In this case, we assign colchicine and inhibitor IL-1. If there is an infection, then we give preference to colchicine and NVP. If there is a liver dysfunction, then it's IL-1 inhibitor. Here is the dosage for a compromised kidney function. If it's more than 50, then it's 0.5 milligram 2 times a day. If it's lower than 10, then we should avoid prescribing colchicine at all. It may be used in elderly patients with reduced renal function. Here is the target level of uric acids if the renal function is compromised. So this is according to different societies that are dealing with rheumatitis. And according to European Rheumatitis League, the target is 360 micromole per liter and below. If there is a serious toughest gout, then it should be 300 micromoles. American College of Rheumatologists believe that it's sufficient to lower below 360 micromole per liter. So the French Society of Rheumatologists recommends for all set it as the target, as a threshold 360, but preferably lower is better, around at around 300 micromole per liter. So this is the concentration of uric acids when it's dissolved in its own liquid environment of the body. So after you ensure that you relieved the attack, you need to lower uric acids, and for that we prescribed two drugs. It's allopurinol or febuxostat. If there is some intolerance of allopurinol, or you cannot achieve the target level of uric acids when receiving allopurinol, then you switch to febuxostat with a dosage of 80 milligram a day, or when necessary you can increase it. So the next one is urate lowering drugs. According to European recommendations, they prescribe allopurinol with low dosage depending on the speed of filtration. The European College of Rheumatologists suggests to always start with allopurinol. It all depends on glomerular filtration rate. Here is the slide that tells us about effectiveness and safety of febuxostat application to reduce urate for in patients over 65 years old. So we need to determine the glomerular filtration rate. If it's lower than 60, then we need to start with the therapy with febuxostat. There are drugs that, besides its primary effect, have additional or secondary effect. The drugs I mentioned here, its secondary uric acidic effect. They block the vectors of urate. And they remove uric acid out of the body. That was losartan. Here is not sartans but sartans that better be prescribed in patients when they have hypercholesterol. Zinrat and urinrat, sugar-lowering drugs. This is natrium glycosium type 2A. It's a new class of sugar-lowering drug that inhibit glucose reabsorption in the proximal convoluted tubule, and they have uric acidic effect. Now about prevention of arthritis attacks. You need to discuss it with the patient, what you want to start with, and you need to do prevention of arthritis by a low dosage of NPVP or colchicine. Should be discussed and prescribed in each case if there is no contraindication. If there are no contraindications, here is a retrospective analysis when consuming febuxostat that is used as a uric lowering therapy. The patients, to prevent attacks of therapy of gout, they were consuming prednisolone, and the other was using colchicine. And the authors came to a conclusion that colchicine is superior in prevention of attacks. As for reducing the intensity of pain, colchicine and glucocorticoids are equally effective during attacks. when consuming colchicine with a dosage of 5 milligrams a day, amid laureates lowering, one is using allopurinol, another febuxostat, and colchicine a dose of 0.5 milligram per day for 6 months after the start is safe and reduces the frequency and severity of arthritis attacks. Naturally, patients with gout need to revise their lifestyle. They need to limit alcohol intake. That's strongly recommended, or at least partially. Limit the intake of foods rich in purines. Limit consumption of high fructose syrup that increases level of uric acid. Adding vitamin C as a supplementation. It is to be thought that it helps, and that vitamin C has this uric acidic effect, but according to the latest findings, it's not recommended for patients with gout.
So the gout patients shall cancel or discontinue diuretics because they can contribute to an increase in the urine acid levels and the development of an acute attack of gout. In cases where diuretics cannot be discontinued, especially in terms of chronic heart diseases, then in that case it is possible to have a care monitoring of the level of uricemia while taking the drugs, and if necessary, the addition of allopurinol are indicated. The choice of losartan is preferable as an antihypertensive agent and is recommended for patients with gout regardless of disease activity. Discontinuation of low-dose aspirin for patients taking it for appropriate indications is recommended for patients with gout. Now, it takes special approaches to treatment of gout, prescription of sartans with uricosuric effect or losartan, prescription of B blockers with protective ability in relation to metabolic disorders such as carvedilol, and use of the safest diuretics. This is the safest one, which we call spironolactone. Now, as for the recommendations in patients with gout, there is no preference for a particular urate-lowering drug from the cardiovascular point of view. Your recommendations on managing cardiovascular risks. When they have different kinds of diseases, the current guidelines recommend allopurinol as the first line of therapy, and it is followed by febuxostat. Okay, I think I'm done. Well, in conclusion, I just wanted to, well, my conclusions reflect the content of my lecture. Thank you for your attention. Thank you very much, dear friends. As the moderator, I wanted to remind you of the time limit, and once your time is up, please pass the floor to the upcoming speakers. Dear friends, our next speaker will talk about how to develop artificial intelligence that can help to manage hospitals efficiently. I would like to give the floor to Shahislam Sahi. He is the entrepreneur, neurosurgeon, and neuroscientist. I will give my presentation in English because we have the simultaneous interpretation.
Scientists, doctors, and innovators of healthcare. So let's start with a quick survey. Please raise your hands if you are a software developer or future doctor or entrepreneur. Before I dive in, so you know, my presentation won't get too technical. I won't go through all technical steps of creating AI, such as preparing the data, filtering it, creating database pile, training it, and tokenizing, validating, and deploying it. So what I'll try to explain are the principles on which the entire process is based. So what is AI for healthcare management? So is it for doctors to help with the diagnostic support, treatment planning, or patient monitoring? Is it for patients to help with health monitoring, personalized health insights, and remote care? Or is it for business to help with the resource allocation optimization, enhanced patient care, or streamlined workflows? So in my opinion, perfect AI for healthcare management shouldn't be narrowly focused on just one of these aspects that mentioned above. It should be comprehensive, helping all stakeholders from the patient to government. It needs to have tools relevant to all these participants of ecosystem. Now the question remains, how to create such AI? We have managed to do this. We have achieved good results with our launch in India. Our products assist both. So you see, for patients, both doctors, patients, as well as hospital managers. Trained, T-R-E-I-N-T, stands for treatment intelligence. If you will Google it, Trained, we are among few companies in the world that implemented this definition in this industry. So for patients, it helps identify the most probable diseases in just 3 minutes by asking patients 10, 15 questions with accuracy, 97% accuracy rate. This empowers patients with timely information and facilitating quicker access to treatment. For doctors, our AI provides real-time insights into patient care efficiency, measuring average treatment efficiency, and offering personalized feedback. So for hospitals, our AI revolutionizes business efficiency metrics and tools, offering comprehensive data-driven insights into service quality, doctor efficiency, and maximize overall hospital efficiency. Before I will explain my vision on how to create AI, let me introduce myself. I'm Sheikh Islam Sahi. I'm past the journey from being a doctor to becoming a tech entrepreneur. I am the founder of the Train Corp, which is based in the USA. And I followed the footsteps of my grandparents, who were doctors. I trained under the best doctors in Europe and Kazakhstan for 7 years, and assisted top neurosurgeons like Roberto Delfine or Joachim Ortel in Europe, and started my own business at 16. So my passion for entrepreneurship led me to explore digital healthcare in different countries and different level hospitals, where I saw many problems and opportunities to make improvements. This inspired me to create a company that can change digital healthcare forever, and I hope so. So in 2019, I convinced the idea. 21, had a company, launched a company in Kazakhstan, I conducted the test here, and subsequently 22, established a company in USA and rebuilt a team in India, with the most members hailing from India and the USA. And additionally, we are enlisted medical experts from various countries around the world. And 23, we commercial launched in India. And 24, we process about 250K services per month, and totaling around $5 million USD per month. Moreover, we have been nominated by WSA, World Summit Awards, and the United Nations as one of the top 100 best digital solutions in health and well-being. With this wealth of experience, I aim to share my vision on creating AI for healthcare management. So, first step is R&D, of course. It's crucial to thoroughly understand what you are building. Before you start even think about it, it is, for instance, as a young medical student and later as an intern, I spent a lot of time researching various aspects of hospital operations and patient treatment process. I observed everything from how receptionists work to the hospital management. While it may have seemed like I was just wasting a time, It was actually an invaluable preparation for me. By immersing myself in hospital across different countries, including Europe and Kazakhstan, I gained first-hand insights into the needs and challenges faced by doctors, patients, and hospital managements. I totally understand what do they need, what their expectations from us, whether in the healthcare industry or IT sector. So you can say my R&D spans 7 years. Sorry. Okay, you made an R&D. Even if you fully grasp what doctors, patients, and managers expect from AI or a system, don't rush into creating a mobile app or SaaS platform. There is a risk of simply digitizing chaos. Instead, take the time to assess if existing process need revision or if a complete overhaul if necessary before digitization. So before digitization, you should just dive into the business process of the hospital or the treatment process. For instance, many experts in the past and software developers advised us in the very beginning that we didn't need to complicate our system and that we shouldn't just create an online appointment service. We just should create a simple service. But however, online appointment system alone cannot solve queue management. This is just a simple example. Then after, if you will even made a good R&D and optimize good workflow, you need to set the right goal to create exceptional AI for healthcare management. And the goal to increase the income, just to increase the income, it's not enough. And I think it's not the right goal. The most right goal for the AI in healthcare management, even for businesses, should be the treatment efficiency. For instance, our platform meticulously designed with these objectives in mind. For example, a hospital efficiency hinges on the efficiency of the patient treatment and average efficiency of every doctor. We recognize that hospital cannot operate efficiently if patient treatment efficiency diminishes. This is a simple example of it. So even sometimes startup developers overestimate the role of software developers and forget about the role of medical experts when we talk about AI for healthcare management. It's crucial not to overlook the involvement of doctors. Instead of hiring 100 developers, data analysts, and computer scientists, prioritize assembling a team of medical experts. It's better hiring 100 medical experts, guide and instruct 10 developers, and data scientist specialists. And by that, you ensure that the AI you're developing is rooted in practical medical knowledge and address the genuine needs of healthcare. Then, when you develop it finally, be open to the community. When it comes to building AI, don't hide your ideas or be afraid to share them. Embrace openness because the public can provide the invaluable contribution to strengthen your AI. For example, we plan to open our code and to AI developers or medtech developers. So of course, this collaboration will ultimately make our AI stronger and more effective than ever before. Then, when you finally created an AI, onboard right clients. When you introduce something new, not everyone gonna like it, but don't let that stop you. Keep working on that, keep developing that, keep introducing to the market. You will find the right client. So that client who is ready to change with you, who is the same innovator as you. And when you finally dealt with R&D, finally optimized the chaos in a hospital, optimized all the business process, treatment process, build a team, and onboarded the right client and launched your product. So the next advice is just don't panic, keep working, keep improving the healthcare industry. And yeah, that's it. Thank you. This is the QR code that leads to our website where you can discover our product and the team. Thanks.
Shaykh Islam Sahi, thank you very much. It was very brief, but yet very informative and to the point. Ladies and gentlemen, our next participant is going to share his knowledge about medical and social rehabilitation of comorbid elderly for active longevity. So let's welcome here Gleb Krasnov, who is the geriatrician, research assistant of the project of the Satpayev University. Good evening, dear colleagues, guests, and spectators. My name is Gleb Krasnov, and as it was already mentioned, I'm the research assistant of the project at Satpayev University. I'm the scientific consultant of the Longevity Center in Almaty, and I'm the co-founder of dosatar.io IT service. So today I would like to briefly talk about the experience that we gained in Almaty as part of the work of the Center for Active Longevity. And my presentation will consist of 4 parts. The first part is the description of the infrastructure with which we interact, and the first part will be dedicated to how we work with elderly people. Second part will be about research, design, and expected results. We have here several studies which are intended for elderly people, and we will provide some information on this. Third is innovations, which help us change our worldview and mindset, geriatric mindset, which is characterized by a special approach to patients. And the fourth part will be about our vision within the next 10 years. So in Almaty and in Kazakhstan in general, we have the following infrastructure, which is supervised by our group. We have 4 centers of active longevity. We have 3 groups of 3 based in Almaty and 1 in Uralsk. Patients there have 4 groups of activities that are aligned with the domains of the geriatric evaluation of the health of patients. There are 3 groups of scientific and innovative projects, and these activities are observed by more than 3,000 followers on social media. If we speak about the domains activities, we have the physical health domain, where we provide the consultations, medical checkups of geriatricians. We revise the therapies or de-prescribing. We also have the element of the biological feedback or biofeedback. This is the game practices that allow some intuitive control over certain indicators, and such tools are used by the centers of active longevity. We also have the physical activities. For example, our patients, elderly people, do gymnastics, yoga, aikune, physiotherapy, and Nordic walking. There are also some classes on fine motor skills development, mobile literacy, and IT literacy. These are so-called instrumental activities for people of elderly age to communicate better in line with the contemporary changes. The domain of mental and cognitive status is presented by consultations of psychologists, counseling, trainings, different activities that improve the mood of elderly people, such as singing in a chorus, poetry, or other creative activities, such as dancing or excursions. And the assessment of the cognitive status is carried out as part of the doctor's consultation, who is also a geriatrician. Socialization domain consists of language courses and social practices, such as game practices, as well as the legal assistance and finance counseling, financial counseling, because elderly people who are left without any assistance or help may deny the reality and stay in their memories thinking of what life used to be in the past. So we support them by helping them stay in their reality, by ensuring them with the communication tools, and this is how we support our patients in the Center of Active Longevity. On this slide, you can actually see the structure of medical and social services on the basis of one of our centers of active longevity. So in 1 year, there are 24 or 25,000 unique visits, and the coverage with our services accounts for more than 60,000 services, which means that per one elderly person, there are about 2.5 services provided at our centers of active longevity. And if you want to learn more about the activity of our center of active longevity, you can use this QR code and look at the website, look at the contacts indicated there. I'll give you 10 seconds for you to scan the QR code. I see that some people are trying to scan this QR code, which is good. Okay, I'll give you a few more seconds, 5 to 10 seconds, and then we will move on. Now let's move to the part that is related to research. The first is the ecology and geriatry. Together with Satpayev University, we hold studies related to the assessment of the environmental situation. We have several sources of data about the environmental pollution. These are the stationary sensors that show air pollution measurements, and these are the drones which also can provide information about some areas in the city where there are no stationary sensors installed. So these are the technical components that help us better assess the environmental situation. And as for the medical part, we carry out RWD, or real-world data surveys. For example, that's when we get into the medical information system and get information about the incidence of diseases and so on and so forth. We get the entire information and align this information with some diseases in order to prove the environmental measurements. We have the observations for several years, and we see the degree of pollution in one part of the city and align it with the pollution in other part of the city and align this information with the information about the diseases of patients, and we identify links between the environmental pollution and a certain disease event which is prevalent in one or another part of the city. So as part of this research, we decided to create this service that allows us to choose the best area for living, and we also provide services with the adjustment of environmental situation in buildings, where we also use the special cleaning devices. We use such devices in order to see some positive results. And in order to fix these positive results in the form of the scientific publication, this is how the drone looks like. It flies over the city, and this is how the smoke in Almaty looks like. If you didn't know, now you can see the smoke in Almaty. If you want to learn more about this project, you can also scan this QR code and look at how this work is carried out. You can see the composition of the working group and learn more about the goals and objectives. It used to be more like an environmental or industrial research, but we decided to combine it with the medical component, and we expect to see or to learn more, even though we already have lots of information. The data which we have already is more applicable to the cities with unique geography, with unique landscape, and respectively, some data may not correlate with the results which we get as part of this research or study. Another area of work of the active longevity centers is the post-COVID syndrome among elderly people. All of the symptoms developed after people got COVID, and these symptoms can only be explained by COVID, and there are about 50 symptoms as part of the systemic reviews, and these data will be complemented by a greater amount of information. So we have an opportunity to make a contribution to the development of consequences of the pandemic. And we also have some studies held, and our working group is working on the systemic review. We also have the journal club, which updates data on a permanent basis. And here we have updates not only from Satpayev University, but from the Kazakh Russian Medical University, Federal Research Center of Fundamental Translational Medicine of Russia, and Digital Doctor LLP. The expected results include the recommendations for patients with the post-COVID syndrome, as well as the creation of structural units for monitoring and correction of the conditions of patients. Which means that there are certain conditions with regards to which we can actually improve the current practices. And we plan to improve this even more. This is Marks Borisovich Stark, the academician of the Russian Academy of Sciences and the head of the biomanagement that is also applied for these studies. And this is the picture of our journal club, and here we work on the analysis of the publications. For example, as part of the para-academic hours, we have to publish several articles, and we have to talk about these articles in order to improve our analytical skills, literature analysis skills. We also have statistical information about COVID-19, and we also plan to align this with the environmental studies. Next area is the oncogeriatrics, and there is a saying, all oncologists are geriatricians in some way because they have some experience in interacting with elderly people, and respectively they hold prospective cohort studies as part of this research with the historical information, and we carry out comprehensive geriatric assessments in order to identify the combination of tests which would be more applicable with regards to patients with the oncological diseases. And this helps assess how patients with asthenia can be differentiated from other patients. So this helps us see for how long the patients need more care and how much financing is needed. And respectively, we plan to get the protocols for management of the geriatric patients in terms of oncological inpatient treatment. In this area, we receive help from Almaty Regional Hospital, the Public Association of the Young Medics of Almaty, that work with the Centers of Active Longevity, and we also work with Digital Doctor Kazakhstan LLP. This area is what we call the total geriatrics, and this is quite an interesting concept, in our opinion, that is characterized by the principles of geriatric aid to we want to explain these principles to every doctor in a quick manner. Here on this slide, you see the geography of the services, and dosator.io that we use in order to carry out the geriatric assessment. This instrument is used to simplify the dosage of a medication. For example, there is the Fibuxostat that we talked about, that the previous lecturer talked about, and we can help doctors choose the proper dosage based on age. Recently, we used the calculator to determine the target levels of hemoglobin, the blood level for the patients with diabetes, because if we look at the recommendations about diabetes, we will see the target levels, and we will also see that certain geriatric conditions need to be excluded in order to define the target levels. But at the same time, the methodologies of such exceptions are not determined. That is why we came up with this solution that allows us to better identify the level of blood, because if this level is too low, then patients will have the hypoglycemia. And according to the data of the patients with diabetes and hypoglycemia and hyperglycemia, these increases the risk of dementia. And respectively, in order to work with elderly patients in terms of the Center for Active Longevity's operation, together with the new platform, we develop special algorithms without the help of IT experts, and we even carry out some polls and surveys in order to help doctors make decisions. And we, of course, plan to carry out this research on the cohort-based model or prospects-based model or research with the historic control. We plan to collect data from real clinical practices, and we also want to get the geriatric IT module, which is ready to be integrated with the medical information systems. And our partners include the Almaty Regional Hospital, as well as the Association of Young Medics of Almaty, Digital Doctor Kazakhstan LLP, Research Center of First Aid named after Sklifosovsky, and Gerontology Center, Medical Institute Reavis, and HealthNet. So, right now we have more than 100,000 users globally, and we plan to expand the functions, create spin-offs in order to better integrate into practice. Also, the Center of Active Longevity, in some sense, is the innovative platform, and this platform brings together the Young Medics of Almaty, the Association of Young Medics of Almaty, and we held 2 clinical studies. We have 1 international research and 6 active results of the intellectual activity.
And an opportunity to attract target specialists to implement those tests that you see the information companies are tasked with. So therefore, we can develop some digital solution with our own resources. We can combine them with the products of the technical companies and to pilot them as part of those studies that the association conducts. What do we want to see in 10 years' time? We would like to see 10-time increase of our online centers and to shape an online platform for elderly people of Kazakhstan, where they would be able to do a comprehensive patient-reported outcomes and geriatrology assessment when they fill out a survey, and using this one they can tell whether there's an exacerbation of a chronic disease or not. We would like to cover all medical and social workers with geriatric instruments. That is possible to be done with integration with the information system, with the presence of political will. We would like to organize Gero Techno Park and have an ability to attract doctors using crowd engagement model, when every willing doctor can join this infrastructure and interact using the studies that we have. And we would also like to grow in social media 10 times, at least to 30 times to reach 100,000 followers, to translate those values that we have in our team. Here is the team of Young Medics of Almaty Public Association that does all the infrastructure work. The head of the association is Slushash Iskalieva and Almagul Mansharipova as the scientific team lead and methodologist that unites all participants, and she engaged Ravil Mohamediev, technical chief officer, for us to conduct technological studies and to combine this potential that is untapped in the medical technology, in geriatrics technology and technical potential. We're open for cooperation. I'm a senior fellow, Gleb Krasnov. Please take a picture of my contact details. I'm a technical specialist, scientific consultant. So have everyone a great night. Thank you. Thank you very much indeed, dear Gleb. And we move on. Our next speaker is going to share her knowledge. It's going to be problems and prospects of gerontological service at primary healthcare stage, Ms. Ainur Nuftieva, candidate of medical sciences, Dean of International Medical School, University of Sagadeev. Good evening, dear colleagues. I realize that I'm the final speaker. I would like to beat and to set the record by delivering shortest presentation just in 2 words, because my report is more about the organizational side of things. Today we heard a lot of talks about everything, including target therapy, integral medicine, and so on. However, I would like to let you know, in order to bring this to fruition, we need to interact with practical healthcare and to organize the system of medical aid to make sure that we can implement all those innovations that we heard about today. If we look at the slide, the world is getting older, as you know. The oldest countries is Europe, Japan, and we're approaching them as well. If you look at year 2050, 1/5 of the globe will be elderly people. We need to start thinking about how we will live in our older age. However, our parents, grandparents, they are of senior age. We need to start thinking about this golden age as early as today. Here are our grandparents. This is the reality that we face in polyclinic. Unfortunately, the aid system at our primary healthcare leaves much to be desired, though a lot is being done, though, by our administration, but our management. However, the system of geriatric aid is not only geriatric services or primary or social care to the population of working age in the usual sense. It's also health. It's the level of aid rendered. This is also organization model. It's how we organize it, where we organize it, what are the resources, what are the staffing. We need to reorient, to change the focus of our medical and social protection system to provide to provision of services to elderly population. So we need to merge our efforts and join hands. We had a wonderful report about rehabilitation just now, but it's unfortunately all non-systemic. These are all enthusiastic groups. These are NGOs. We need to join both government and non-government structures to establish better quality system. It's also a matter of philosophy that is based on the principles of social equality. It's no secret that doctors at primary healthcare, they don't like to work with the elderly population. They think it's a written-off product. It's an expired product. However, they even think that even all person calls an ambulance, not all of them are eager to rush and help them, because it's an old person. Why do we want to save him or her? It's a social disparity, and we need to overcome it and to establish new norm of social relations. And the younger generation should be thankful to the older generation and to align the system of support for the weaker part of the community, social community, and we need to boost the different volunteer movement. Here is an indicator of geriatric aid. I will skip and flick through it. But generally speaking, it's pretty low coverage, and the level of satisfaction leaves much to be desired, and it's not achieving even 70%. So our old people are always dissatisfied with the aid provided. If you look at Almaty, we're using main regulatory documents. When there is a specialty, geriatrician, a doctor, we're using the standards of geriatric aid in our operation that was adopted in 2021, and there was a national action plan to improve the situation of senior citizens and aid provided for them. So we're using these standards. The standards capture all key functions of a doctor. It describes what a doctor should do, a geriatrician should do, and workers with high education, especially of geriatrics, is only 0.2%. So it requires major reforms. I'm sure that I'm talking about Almaty, but I'm sure it's also the case in Astana, to work with the Council of Veterans, different associations that help senior population. Different roadmaps are being developed, which describes aid provision at outpatient level, its rehabilitation and month of a senior person, a lot of activities and events, rehabilitation and treatment, where they work on improving their health. There's different resorts. It's a daycare center that is mentioned here as well. Over here, we see that different medical and social activities are organized. Center of active longevity. And in the report of the previous speakers, he said, you just don't want to live for its sake without the good quality of living. We want to make them live a long time and enjoy good quality of this living. It's a report about different roundtables and so forth and so on. So what I was asked to report the chairman of the Council of Veterans about senior patients. Geriatric offices, they exist only on paper and not on every polyclinic. The gerontology offices are opened. Unfortunately, they exist many of them exist only on paper, and oftentimes the physicians, they just performing the function of gerontologist. So here are some conclusions. We're also supporting geriatricians of Almaty. In 26 public outpatient clinics in the city and 32 private health centers, functioning of geriatricians are performed by general practitioners. And now let's move to the conclusions. Significant changes in the age composition of Kazakhstan towards its aging have a significant impact. Comprehensive protection of elderly should be among the priorities of state policy. Adult people should be provided with optimal healthcare solutions, accessibility to all forms of medical social assistance. Elderly people with a bouquet of diseases need sparing conservative therapy. But first, we need to state that in Astana and Almaty, we need to organize such geriatrician offices, so that the geriatrician was sitting there. It was full-time doctor who would provide full-scale aid for our elderly people. And here are some tips and recommendations. What is needed? Training should be provided. We need to start some cascade training, capacity building courses for geriatricians. And as a head of one of the subsidiaries of university, I feel that it should be included, and that this discipline should be taught for doctors and for nurses. Geriatrics as a subject. So here there are a lot of words, but to sum it up, we can say with one word only: coordination that should improve quality of medical, social geriatrics. Dear colleagues, I'm done. Thank you for your attention. We're all growing old, whether we want it or not, and we will be there one day. It's high time we start thinking, how are we going to live, how we're going to provide our aid for our parents, grandparents, thank you very much. I tried to be brief and laconic, and I'm finished. Over from my side, yes, parents are certainly taking a special place in our hearts. It's a holy topic. So we have the most perseverant who stayed with us. We would like to thank all the participants of this outstanding forum for being so late with us. This was the last report from our Kazakh scientists. Let me remind you that tomorrow on 28th, we're beginning at 10 a.m. with the second day of this wonderful forum, Nobel Fest Medical Innovations, and we await all our guests at 10 a.m. Dear ladies and gentlemen, we call it a day. This was day one of our festival. I would like to thank everyone, and tomorrow on 28th of April, we are going to resume at 10 a.m. in the same room. Until tomorrow, and goodbye.